Good morning and greetings. On behalf of the organizing committee, we would like to welcome you at the conference's second day. It is our pleasure and privilege to welcome the moderator of this session, dear respected Dr. Mishari Al-Ataibi, the president of the Mecca Dental Conference. Dr. Mishari is a member of the education committee at the FDI, and he is also a consultant of aesthetic and restorative dentistry at Security Forces Hospital, Mecca. Without further ado, please welcome Dr. Mishari.
بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله سيدنا محمد وعلى آله وصحبه أجمعين. بداية حقيقة أستغل هذه الفرصة لأبارك لزملائنا الأخت الدكتورة ديمة الشمري والأخ الدكتور محمد الحارثي على النجاح وعلى تحقيق هذا الحدث التاريخي في المملكة العربية السعودية بتنظيم ال IADR AMER لأول مرة في المملكة العربية السعودية، والحقيقة هذا شيء يرجع لنا بالفخر والاعتزاز. شكرا لكم على التنظيم، شكرا لكم النجاح المسبق. Today I have the honor to introduce two of my colleagues. First speaker today, Dr. Fawaz Zu'bi. I know him personally. He is a very excellent speaker. I have already have a good experience before in Mecca and in different conferences. Dr. Fawaz Zu'bi graduated 2007 from Kuwait University, and then he completed a 2-year advanced education in general dentistry residency program in 2012 from the University of Pacific, San Francisco. After that, he pursued advanced training in implant dentistry between 2012 till 2014 in Alabama County Medical Center in Oakland, California. He got master's and doctoral degree from the University of the Pacific, concentrating in health care and dental education. He is currently holding the position of acting vice dean for research and postgraduate studies and chairman of the Department of Surgical Sciences. He received several scientific and research awards, including the IADR prestigious award, Centennial Emerging Leaders Award, for his outstanding scientific and leadership accomplishment. Today and this morning, he will present us a presentation titled Between Scientific Evidence and Marketing Strategies, Trends and Future Perspectives of Digital Implant Dentistry Research. Please welcome Dr. Fawaz to start his presentation.
Do we have a microphone that we can walk around? All right. Bismillah ar-Rahman ar-Rahim. Thank you very much. Thank you, Dr. Mishari. First, I'd like to thank the organizing committee, represented by Dr. Adima and Dr. Muhammad, for this kind invitation and for what we have as an excellent meeting here in our dear Riyadh. Today, I'll be speaking about how implants are trending, what's the research that's trending in the market, and how the marketing strategies can either help us and or actually play against us. Thank you. So why IADR? What does IADR represent to us? I truly believe that IADR has many benefits as a member, However, one of which that I cherish most is the ability to network and create long-lasting friendships in our community. I believe that we belong to a much bigger organization, we belong to a much bigger network that we can benefit from together. And to me, this picture really represents what I claim. The image on the right is me with Professor Takeyomi Kuroda back when he was visiting Kuwait during the first AMER region. And the one on the left is myself, also with Professor Kuroda in San Francisco, forward 10 to 11 years later. Professor Kuroda remembers every little detail about me and about everybody who met in Kuwait, and this really established a great network for us, for me personally, and for us as a division and a region. So if you are a student now, I urge you to not only become a member, also become an active member of this organization. I can assure you that this will benefit you at a personal level and will help advance your career from my personal experience. So why do we conduct research? Why do we do research? This is actually a philosophical question that has been debated for several years. Some of us think that we do research to generate knowledge. Some say we test observations, evaluate findings. Some argue that we do research in academia to get promoted. All true. However, I truly believe that, and I think most of us here believe that research is to benefit mankind. And due to this philosophical question and controversy, we really rely on evidence and our clinical experience to help us judge certain practices in our clinical setting. A very famous study was done by David Dunning and Justin Kruger back in the late 90s, where they kind of tried to evaluate confidence and competence and see what is the relation, and came up with what we know as the Dunning-Kruger effect. Now, this is a widely accepted illustration of what a lot of scholars think it might be an oversimplification of something that is very complex, like a metacognitive behavior, such as confidence. And I can tell you, in fact, that although we have abundance of literature about experiences, confidence, and competence, we still don't know really what's the exact interaction between the two. However, this illustration seems to be widely accepted. From their study, they found out that when the student or the learner graduates from a certain program, whether a postgraduate or an undergraduate, they seem to be extremely confident and think that they're experienced. And as we get along with their practices during their years, they get a bit humbled and they go down in terms of their confidence, and confidence lacks because they start to understand that they have limitations. As they get more experience, their confidence gradually increases until they reach a certain plateau, which ironically is less than what they started before. So this really tells us something very important, that for me, research within the clinical context is important, and we should base our clinical judgment on evidence. However, our experiences, in my humble experience, is very underrated. And I think we should rely a lot on our experiences as much as we rely on the evidence. For me, I think, as I said, experience is extremely underrated. And there comes a question where we kind of question, do we really practice based on evidence? Or do we have evidence, or do you have enough evidence to shape our practices? Another illustration that is very commonly used and widely spread is what we refer to as the hierarchy of evidence. Now, although this is also widely used, a lot of scholars seem to have certain reservations on. I can tell you for a fact, this pyramid has been modified more than 80 times. So really, we need to question things that are widely accepted now in our academic field. I can tell you also from my personal experience that sometimes I get much more out of a good case report than a very poorly conducted literature review. So we really need to take that image with a grain of salt. So what we kind of shifted towards is what we call, or what we refer to as, the Oxford Center level of evidence. And this is what we teach our students. Now, we still believe that this is not perfect, and this does not reflect upon what we think of high evidence, but a lot of academics and a lot of scholars believe that this is a much better representation of what is going on in the research arena. And this is what we teach actually in Kuwait University, and I'm sure a lot of schools are starting to kind of shift gears towards this illustration. So, to me, no one represents the statement that we need experience to shape our practices as much as this person over here. For those of you who don't know this person, this is P.I. Branemark, a very famous orthopedic and anatomy professor back in the 60s. Professor Branemark is currently considered the father of modern implant dentistry or modern implantology. During his experiments, he was mostly focused on bone healing, and to conduct those experiments, he used optical monitors to be inserted in rabbit tibias. After completing what he thought was a very successful study, he tried to basically retrieve those monitors, and he couldn't. And he was extremely frustrated because those come at a pretty high price, and he wanted to kind of use it more and more. He then realized that there might be actually an implementation of this phenomenon, which he refers to as osseointegration. Then what he actually found out that this can be implemented in other areas beside the orthopedic field, which is currently the dental implant field. He was fought and he was argued a lot of times. He conducted so many studies, however, that he really had a lot of resistance from the field. Nobody would have funded that research until he met Mr. Gösta Larsson. Mr. Larsson is a taxi driver who he met Branemark actually by coincidence. Branemark took that taxi, and Mr. Larsson was complaining that his denture was wobbling and he was really frustrated with his denture. And somehow, Professor Branemark convinced Mr. Larsson to get some implants done and hopefully secure his denture. So Mr. Larsson was the first patient who gets implant with no absolute research evidence, even no animal studies done. Mr. Larsson passed away in 2006 after 40 years of service of those implants, with the implants in the grave with him. So not until 15 years later, after Branemark's discovery, the NIH started funding his projects. And in fact, the way he was trying to convince NIH that he implanted titanium plates into the shoulders of his students. He in fact convinced 20 students in his university to implant titanium plates in the shoulders. And those plates were, again, very successful, well integrated. This is something that we absolutely cannot do today. There's no ethical committee that would approve that, but this was how desperate was Branemark was to kind of promote his research. And then he finally got his grant, started publishing his papers. Then, in the early 80s, during the Toronto Convention, implants started to be kind of popular in our field. So sometimes we really lack solid evidence to justify our clinical practices. So this discovery led to an explosion really of scholarly work and papers. One of the most common books in the field is Carl Mesch, Contemporary Implant Dentistry. For those of us who are involved in implants, I can assure you we all went through this book in every page. This is, at that time, was the most popular book, not only in the field of dentistry, but in the field of medicine in general. It is the most cited book in the field of dentistry and medicine at a certain time. So this really reflects the significance of that discovery. However, with this explosion of literature and scholarly work comes a problem. According to the German Institute of Quality and Efficiency in Healthcare, we have around 75 clinical trials and 11 literature reviews submitted every day That was several years ago. I don't want to even know about that figure nowadays. So we have abundance of evidence in the literature, not necessarily strong. However, we need to take things with a grain of salt again and realize that not everything is published might be strong evidence. As we can see in these figures, we see an increasing and rising numbers of publications related especially to implants. A very interesting paper that I went through was this one over here, published in JPD, that looked at the industry support of implant research. And I would advise you to read that paper. However, just for the sake of time, I think this image really reflects what I want to rely today. As we can see that the industry support increased from 1999 to 2019. And unfortunately, very few countries in our region contribute to this industry support. And the authors suggest that because the industry is mostly in the United States and Europe, those papers are coming out from the region most. So maybe we need to shift gears towards having some industry being made in our region to help us promote our research. However, to me, it was very concerning to see this. Most of the industry-supported studies were for the purpose of commercialization. So we really need to be aware of things when we read our papers, and we need to make sure that conflict of interests are declared. Now, again, many advantages come up from those scholarly work and publications. We see a lot of innovations as a result of this. Marco Prandelli came up with the CEREC in the mid-80s, which was the first intraoral scanner. Mid-90s, Newtome and a company from Verona, Italy, came up with the first CBCT scan. Those evolved into much sophisticated machines that we use almost on daily practices, like intraoral scanners, CBCT scans, and 3D printers. So not all industry-supported papers will kind of deceive you. Some will lead to very great innovations that we use in the field in daily practice. So going to our topic, which is digital dentistry, I don't recall any agreed upon definition of what is digital dentistry, I apologize. However, this to me is the closest when we relate it to clinical scenarios. For me, it's very important not to confuse what is electrical to what is digital. So we need to be aware of things when we read our papers and make sure that we are looking into digital stuff and not electric components. Now, the implementation of digital dentistry has been very significant in our field. We see those two papers published that describe doing a root canal treatment using digital guides, which I thought was very interesting because you think in a procedure like a root canal, which really requires very high-end dexterity ability, it would be digitalized and be used in a very sophisticated technique in root canal treatments. So to kind of have a roadmap of my presentation today, I'll just go through each step of what we do in clinic and reflect on the literature and see if we have the evidence to support and what is lacking in the literature to help future researchers or current researchers identify missing links. So first we start with data acquisition, mainly with impressions or CT scans or X-rays. Now we can do this step either digitally or conventionally. The next step is planning. Now we can plan things using digital softwares, as in this case here where I did a plan on a cast where I wanted to extract all the remaining teeth and do alveoloplasty, and you can see that I marked where my alveoloplasty would be on a cast. However, I could have done this in a digital manner like the other case where we did a bone reduction guide and planned our bone reduction. Again, same thing with radiographs. We can use two-dimensional radiographs or CBCT scans to help us plan. Then we go ahead and do manufacturing, which means that we start making the components that we need, whether to execute our treatment or help us plan our case better. In implant dentistry, we use radiographic stents a lot. We can do these in conventional matters or digital matters. Then we can go ahead and fabricate our temporaries or final restoration or even our prototypes using additive methods such as 3D printing or subtractive methods such as milling. Then finally we go ahead with executing our treatment, like in this case here where I treated two patients differently, one with a conventional non-digital manner and the other one with a almost a fully digital manner. So it's very important to realize that we have phases in treatment and we have ways to conduct those treatments. We can do these treatment phases either in a non-digital manner or in a fully digital manner or somewhere in between, which is what we refer to as a semi-digital approach, which is the most commonly used approach nowadays, and especially in my practice here. So let's take this case, for example. Mr. Ram presented to my clinic with obviously the need of full mouth clearance. So I went ahead, cleared everything up, replaced everything with implants, and restored him like so. Mr. Ram is very happy. I'm very happy with the result. It was treated in the conventional matter, non-digital. So why do we need to change? Why, if it's broken, don't fix it, right? Well, I beg to differ, and I'll explain why in a bit. So when we go ahead and talk about digital and look at the advantages of digital, is it really more accurate? And I'll talk to you about accuracy in the digital implant arena. Is it really faster? Is the patient more comfortable? This maybe I would agree with. Is it cost effective? Well, I can assure you that initially it's not. However, it is a good selling point for a private practice. Now, we see this in social media. A lot of private practices claim that we are digital and so on, just to reflect that they have a sophisticated tool that they treat their patients with and have it as a selling point. So it's very important to be aware of these matters. So let's talk first about the surgery. In a partial edentulous case like this was done with our student, Dr. Dalal Marafi, who is a perio resident now at King's College. So what we did with Dr. Dalal, we pretty much treated this case in a conventional matter. We had a wax-up, did a radiographic stent, sent the patient for a CBCT scan, and placed the implants almost in a non-guided fashion, very conventional way. And as you can see, very good result. So let's expand a bit and talk about the full arch case, which is a bit more sophisticated. In this case, what we did is I replicated the patient's dentures and made a radiographic stent out of it. You can make radiographic stents using barium sulfate, fiducial markers, or gutta-percha. The point is we need to relate the position of the teeth to the bone. And then we basically convert that denture into a surgical stent, go ahead and place the implant. And this is Mrs. Layla, extremely happy. We exceeded her expectations. I am happy as her clinician. And this was treated in a pretty much conventional way. So why do we need to change? If what we have is working for the last 30 years, why do we need to change? Do we really need to make things easier? And I don't think of it as change as much as a natural evolution towards something that is simpler and faster, faster, and safer. And when we really refer to simpler, faster, and safer, we start shifting our mindset to digital dentistry and guided surgery. Now, this raised many questions, which was answered back in the early 2000s. Is really guided surgery using digital tools safer, faster, and more effective than freehand or conventional? Well, simply yes. We have abundance of literature that says so. However, I'd like to dissect within this literature because I really think that there is more to the question than the answer. So when we talk about guided surgery using digital tools in the surgical arena, we really have three types. We have the static guided surgery, dynamic, and robotic. I'll be talking a lot about the static, mostly because it's the most commonly used, it's the most commonly studied in the research field. I'll also be talking a bit and highlighting the dynamic and robotic component, which is becoming very popular in the last year or two. So with static guides, we have a case like this, which we had the pleasure of treating. What we did is we had a scan, CBCT scan, and an intraoral scan, merged those two images together to come up with a plan. And then this plan was translated into a surgical stent that was printed and used intraorally. The stent was used throughout the surgery to place the implants, and as you can see, we have reduction handles over there to decrease the size of the hole through that stent to accommodate the drills. And we delivered the implants later on. Now, this method is not new. It's been studied for several years, and we have abundance of literature supporting its accuracy and its superiority to freehand or conventional ways. So what we thought back in 2016 when I was in San Francisco, we conducted a study and tested a theory that maybe we can use digital methods in immediately placed implants. For those of us who do immediate placements, we know that it can be a challenge because the drills keep on deflecting because of the slope of the lingual or palatal bone. So we might question our accuracies with immediate, so we thought maybe using digital tools would improve the accuracy of immediately placed implants. And this was published in 2016, and I'll be more than happy to share the full text if anybody's interested. And what we did is we did something similar to what we did with the delayed approach. We had the plan, merged both images together, printed a model, and on that model we had an implant replica and a temporary tooth ready for immediate placement, immediate temporization, sorry. Surgery was done. Tooth had great stability, immediately loaded. And then what we did is basically merge the images pre-op and post-op to see if we have any differences. Now, back then in 2016, we did not have sophisticated softwares to help us have more accurate results. Now we have what we refer to as best fit algorithm softwares, which are much more accurate in terms of finding differences between pre-op and post-op scans. And this is something that is widely accepted now in the literature. No one can publish something now related to implant accuracies without using best fit algorithm softwares. So what we did back then, I spent many hours trying to merge those two images and get the correct 3D orientation of the pre-op and post-op CBCT scans, and compared them to what we refer to as delayed implant placements. And we have back then, those studies, those results were pretty significant because we did not see differences between the delayed approach and the immediate approach, meaning that we can use guided surgery in the immediate approach with relative predictability. So this concept kind of evolved a bit more towards the completely edentulous case, like in this case here, where we classify static implant guides into three main components for the full arch cases. The first one is going to be the tooth-supported guide, where the guide is supported by teeth. The second is going to be on mucosa, where the guide sits and basically secured on mucosa. And the final and third one is where the guide fits on bone, directly on bone. And we know from the literature that tooth-supported guides are the most accurate ones, simply because the support and stability is much more superior than mucosa or bone-supported guides. However, in most full arch cases, we don't have the luxury of being completely edentulous and having, we don't have the luxury of having some teeth around to support the guides, so we needed to be a bit more innovative. So what we came up to, or back then what scholars came up with, is having anchor pins, the ones that you see over there, in a tripod manner, especially in a completely edentulous case where we don't have any teeth to support. And this would increase the support and stability of the guide, hence the accuracy. So what we did also back in 2014, we conducted a study and coined, at that time, was a relatively new concept, where we used it to facilitate the workflow for the full arch cases. So what we did is we took patients with terminal dentition like so, and then we planned the case after the alveoloplasty and implant placement, printed those models, and on those models we made guides to guide the pins, the anchor pins, not a guide to guide the implants in a tripod manner. So now we know that this guide is extremely accurate and helped us locate the anchor pins. So this was the only use of that guide. Then sequential guides were made with exactly the same position as the anchor pins. Those included bone reduction guides, like so, and implant guides. We went ahead and had the replicas on the model and prepared our denture for immediate loading. So to the clinical scenario here, we had 3 guides, went to the patient. After placing the first or tooth-supported guide where it helped us locate the anchor pins, we went ahead, removed that guide, placed the bone reduction guide at exactly the same position as the anchor pin. So now we have the accuracy and the luxury of having tooth-supported guides. Completed our alveo, went ahead, placed the implant guide, again, exact same position as anchor pins, and immediately loaded the case. This is how the case looks. So back then, we published this as a proof of concept, and our results were relatively promising at that time. Now, those numbers are probably not going to be acceptable nowadays because we have much more better and sophisticated tool to help us. But to me, this was the first paper that described such a method, and it kind of created a ripple effect for things that we actually do today, and I had the luxury of doing today. And a lot of companies started investing. And one of the most popular ones is Smile in a Box. We have many companies now that do those services. In fact, if you have a sophisticated CAD/CAM technician with a good lab, they can actually make that for you. So what I did in these cases, I started using them a month ago maybe with this case over here where this patient came in with a terminal dentition. Now, something that we actually started implementing at Kuwait University, especially with the oral maxillofacial discipline, is 3D scanning. These help especially when you're planning a fully digital workflow in terms of doing your plan. You can superimpose a digital wax-up on those images and have a much more dynamic view of the patient's try-in. However, they do come at a cost. And I would suggest if you want to start doing 3D facial scanners, I would invest in the smaller portable ones instead of the bigger ones, especially if you're in clinical practice, not in academic settings. However, they can be a very valuable tool for diagnosis. Went ahead and did intraoral scanning. CT scan was made, and the DICOM CBCT file was merged with the STL intraoral scan to come up with a plan. And now we can have a dialogue with the lab technician that will help us plan the case in a much more accurate way and start planning our guides that we were going to use in surgery. So basically a 3D printed model is made, and on that 3D model, guides are made. So in this case, we did not want to make any alveoloplasty in the posterior. So what I did is I placed the implants in the posterior with no alveoloplasty. Then, and I wanted to notice the anchor pin positions are exactly maintained at the exact same position. I went ahead and did a bone reduction guide with the exact anchor pin position. And on those guides, the final implant guide is made. So now we are maintaining exactly the same position of the anchor pin. The only difference between this and the study that we conducted is that we don't need to remove that guide. And this is what we refer to as stackable guide systems. A temporary is made over this and stacked over the bone reduction guide. Again, a reduction handle was used to decrease the osteotomy size. Posterior implants were placed in a flapless manner. Then we went ahead and placed the bone reduction guide, extracted the teeth, did the alveo, delivered the remaining 2 implants. and this is what you ended up with. What we then did is immediately load the case like so. And this is how the patient walked out of clinic. So we see a lot of methods now, and I can tell you this is becoming very popular in the market, especially in Europe and United States. However, unfortunately, it is not very well tested in the literature and the research. So if this is a field that you might be interested in, I would highly encourage you to do an accuracy or a precision study to evaluate its whether or not if it was precise and accurate. However, it is becoming very trendy now in clinical practice, which is a bit surprising to me because it's not trending in the literature yet. Another case, Mr. Mutlag came in with obviously the terminal dentition, mostly focusing on his lower teeth. Now, Mr. Mutlag is in meetings in and out. He cannot tolerate a removable denture. And for him, something removal was not an option. So we needed to do immediate placement. With immediate placements, we need to assure that we have good implant stability. So what I did, I placed the posterior implants first, waited for those to heal. After healing, I placed scan bodies and scanned the case. Now, for those of us who are involved in digital dentistry, we know that scanning a case with teeth is much more accurate than scanning a case without teeth, simply because teeth are considered fixed reference points that the scanner can detect. Without teeth, it's going to be very hard for the scanner to basically have an appropriate impression. After scanning the case, we went ahead and planned what I refer to as a fixed surgical guide and an immediate interim prosthesis. So what I did here, I created two windows on both sides where I planned to place the remaining two implants. Went ahead and milled PMMA, and as you can see, this prosthesis is fixed on the implants after extraction and will facilitate the surgery. However, at that, I wasn't really comfortable with going with a full digital workflow, especially when it came to full arch cases and immediate loading. So what I did is, in combination with that, I did an analog workflow or a non-digital workflow. Like in this case here, after making a master cast, and I marked and I created the residual ridge to have an ovate pontic shape to facilitate hygiene and emergence profile. So what I did is I just did a conventional implant impression after splinting both impressions. And something that we do in full arch cases is we need to verify the casts. We need to make sure that the cast is accurate in full arch cases. Otherwise, everything is going to be deflected. So we use a verification jig. However, in a case like this, this is not your conventional verification jig, simply because we cannot go cross-arch. In this case, I had to basically do a transverse verification jig, delivered it in the patient's mouth, and confirmed that the abutments are seated. Now I know my cast is accurate, my digital impression is accurate. And this is something I highly advise you to do if you're going to implement digital dentistry in your practice, especially with full arch cases. Don't go solo. Don't go only with a fully digital workflow. Always have something as a backup, especially when you first start. Have 30, 40 cases under your belt. Feel comfortable with digital. Make sure that the literature supports it, which it doesn't for now at least. And then start going fully digital. So what I did is basically conducted the surgery. After extracting the teeth, I secured the prototype on the healed implants, went ahead and placed, I was planning to place two, but I added the third one because we didn't achieve good stability in one of them. But I used that as a surgical stand. Then I converted it into a temporary, simply after fixing it into the cast and filling the windows with acrylic. Now, this acrylic will shape the intaglio surface and give us the ovate pontic shape that we always aim for, especially in full arch cases. And as you can see, this is how we deliver the case. After healing, what I went ahead, and Mr. Mutlaq was very happy with the result. Video was great. Everything we wanted in our final restoration worked out very well. So what I simply did, instead of making new final impressions and all of that, I simply scanned the teeth or the denture, and then scanned the implants and asked the lab to merge those images together to fabricate a final prosthesis. So the next system that I want to talk about is the dynamic system. It is also gaining popularity. However, we think that this is something new. It is not. It was introduced in the market back in 2012 and 2013, where I had also the luxury and experience to not really work with it closely, but introduced to it. We were told that this was going to be the future, and I can assure you it's not the future anymore. Now this is becoming very popular in the market simply because a very big company bought that system and started to market it. However, we do see some support in the literature supporting its accuracy. Now this was mainly made to address the limitations with static guides. And the literature, although very scarce, is promising when it comes to dynamic surgical guides. So the next system is what we refer to as robotic. This is something that is very trendy now, very new. It's been published in the last 1 or 2 years only. Again, extremely expensive equipment, yet extremely popular both in the delayed and immediate fashion. And I do expect a lot of papers coming out within the next 3 to 5 years addressing robotic and dynamic systems. To me, this paper was very interesting, not because it describes and reports the results of the accuracy of robotic system, but because of a figure that was in there that compared all systems together. And as we can see, on the left-hand side, we have the robotics, the middle we have static, and the right hand we have dynamic, where we are comparing the results. It's almost like a meta-analysis of all of these guides. And we can really, if you looked carefully, the numbers between all those 3 systems are not much different. So maybe static guides are still the gold standard when it comes to digital workflows. So why don't we have perfect solutions? Why don't we have extreme accuracy or 100% accuracy? Well, simply because we have so many errors that can build upon during our workup that will reflect on the end product. I don't want to go specifically through these errors, but a very good paper that describes those errors is this one over here, published in Clinical Oral Implant Research, which describes those errors. And it kind of identifies errors based on the stage of the planning and execution. I can tell you, for example, when I look at a CT scan of a patient of a full arch case, I think I have it all, and I think I figured it all, but I have the luxury of working with 2 wonderful radiologists, Dr. Maria Baghdadi and Dr. Arif Al-Awadi, and I can tell you when I call them and ask their opinion on those scans, and they do their thing and play around with the settings and have a much better image to work around, it's almost like looking at a different patient. Now imagine if I was the daily clinical practitioner with no support from a radiologist or someone who's really experienced in that field. I'm already having that error to start with, yet along the manufacturing error and the design error. So those errors kind of build. Now, to answer the question, is there a difference between the way implants behave in clinical practice, whether placed using digital tools or using non-digital tools or conventional tools? This is a very nice meta-analysis that kind of concludes and reports a very interesting finding. No, there is no difference. There is no difference in implant survival, implant success, or any of the success parameters like bone loss, fractures, or mechanical problems between implants placed in a digital manner and implants placed in a conventional manner. Again, we need to take the literature with a pinch of salt and be very careful about what we translate in our clinical practice. So let's go ahead and talk about the prosthetic part of the treatment. Again, same thing, different phases with different workflows. Another student case, actually the same case that we did in surgery, where we did a conventional implant impression, delivered the case with no digital component. Again, very successful, very nice outcome. However, Do we have similar outcomes with digital tools? Yes, and this is highly studied in the literature, like in these cases here that we had the pleasure of treating at Kuwait University, both a single unit case and a partially edentulous case, like so. Sorry. I apologize. So both for the partially edentulous and the single edentulous cases, we have an abundance of literature that supports their use, their accuracy, and their precision. However, it gets a bit more complicated when we talk about the full arch case. With full arch cases, again, we are missing fixed reference points. Hence, the scanner can't detect accurately the 3D orientation of those implants. Hence, the accuracy might be a bit compromised, especially in the full arch case as compared to the partially edentulous, like in this case here. Now I started implementing a digital workflow, but I always supplemented with a conventional one, like in this case here. And the literature is pretty controversial about the accuracy of such treatment approach. Now, for those of you who are not aware, those the white components are called scan bodies. They are the impression copings in a digital workflow. They help us orient the 3D orientation of the implant inside the patient's mouth to the digital model or the cast. And we know that so many factors influence the accuracy of such scan bodies. To name a few, this is a list of what the literature suggests that impacts the accuracy. So this is a relatively long list, hence we need to question we need to question things before applying it to our clinical practice. I'd like to focus on the technique simply because this is, I think, the most clinically significant parameter and the most studied in the literature now, and it's even very trendy nowadays. A very significant author is Ryan Mizumoto, who publishes a lot on these types of studies, and I think he's a name to look out for. His papers are the mostly cited and widely referred to when it comes to full arch digital impressions. So Dr. Mizumoto tested two hypotheses. He wanted to see if the scan body type has any influence on the accuracy, and he wanted to see if splinting or having more fixed markers had any effect on the accuracy and the speed of the scanning. So what he did is he had 4 models, one with no fixed markers, a second one with fiducial markers, which are like rounded materials with an adhesive that they can attach to the gingiva. And he used PIP to mark the gingiva to help the scan detect more fixed reference points. And he splinted the the scan bodies with floss. His results were quite interesting because the hypothesis was because we had more reference markers, our accuracy is going to increase. However, it didn't. And he got inspired by splinting those copings from our conventional workflow. In our conventional workflow, we splint impression copings to minimize distortion between the implants. And he thought that translating this into the digital arena might also help. However, his results show that although scan time decreased, it did not help with accuracy regardless of the technique and regardless of the shape of the scan body. So again, this triggered many studies, and a lot of people started investigating the influence of splinting the scan bodies to improve the accuracy. Here we have 2 very popular papers contradicting each other. One says splinting improves accuracy. The other says not really. So we're back to square one. Until our scholarship holder, Dr. Kawthar Ali, who is now a very promising faculty in Kuwait University, did her master thesis on an in vivo model. So before that, we have in vitro models that really didn't reflect a lot on a clinical scenario. Her study was the first to report in vivo results, and again, there was no influence of splinting those copings together. However, scan time was faster. So this really triggered a lot of investigators to start thinking about other techniques to help us improve the accuracy, until really a revolutionary paper came out by Panos describing a very unique technique that I have the pleasure of also using, and I can assure you that at least in my practice it worked very well, and the literature supports it very well as well. So in his paper, he describes this technique where he adds fiducial markers on the palate using adhesives, scan the provisional restoration with the fiducial markers, remove that provisional restoration, add scan bodies with exactly the same position as the fiducial markers, scan the same scan. Now, the software can easily merge those two images together because of those fiducial markers and have a much more accurate representation. Then he goes ahead and prints a prototype, which he tries in the patient's mouth, fits and checks all the parameters needed, and then go ahead and make a final. So this, to me, was the first paper to describe a true, fully digital workflow for full arch cases. Panos goes ahead and validates his results with multiple studies, including a cohort study that he published last year with a report and conclusion that supports the statement. So now we evolved into something that is staying away from intraoral scanning and have something that we refer to as extraoral scanning methods using fiducial markers. Using optical markers like those here, look like guides. And someone named Panaroka also started publishing in this. Now, this is not a new technique, by the way. This was published by Torsten Jent in the mid-90s and the late 90s. However, it didn't get really popular, and I'm sure a lot of you have seen this on social media. And just because of time restrictions, I need to kind of go through this very quickly. Something important here when you're conducting such research is we need to basically have a reference in terms of implant positioning on the cast. To do so, we use something called coordinate measuring machines. This was done before. Coordinate measuring machines are not done anymore. We use lab bench scanners, which are much more accurate than coordinate measuring machines, like the ones used in this paper. So this was a different method called a best fit algorithm method, which basically, instead of manually superimposing those images and using what we refer to as zero access method to compare the deviations, which is not accepted anymore in the research, and you will not get the publication if you are using this method, using a software called best fit algorithm would help you have a much more accurate superimposition. And this is what they did in this study as compared to the previous one. I apologize if I'm just running through this very quickly. So photogrammetry is also being supported by the literature very much nowadays, and I do expect a lot of papers coming out in the near future and in our clinical practice implementing photogrammetry, and one of the most popular ones is PIC or PIC. Another one is called ICAM. We have something that is also trending now called the microplanar. Those are all extraoral systems that help us capture implant positioning, and we need to see more and more support of those systems. And I think now is a good time, Dr. Mshari, to stop. So I apologize if I can't complete that presentation, but I'll be more than happy to talk to you about and give you the slides of the future slides. And I apologize if I'm running late on that presentation. Thank you very much.
Thank you very much, Dr. Fawaz. Floor now is open for any question from the audience. So I think I have some comments. Can you please, Doctor? I will go back to the beginning of your presentation were the pyramid and the levels of evidence. So, do you classify your cases that you made it in Kuwait? That is very amazing cases. In what level you put it?
Well, I think we are at a very early stage of those things. Now, typically with the research, we start with an idea and then start testing it. Within the research parameter or the research arena, we have a lot of what we refer to as proof of concept studies, which supports it, but it's not one of the strongest evidence that we have yet. So maybe we are not in the highest classification, and this, I think, is an area to explore if you are a researcher. We are very interested to elevate the level of evidence of such techniques with studies coming out from current researchers and future researchers, inshallah.
Personally, I'll put it in level 5.
Sorry?
Personally, I'm putting it at level
Let's
5,
go
which
there,
is
yeah.
it's about the expert, there is no, enough research to support all these things, but it's very promising. And as you mentioned in the beginning, Bronemark, I met Swedish people when they introduced the flapless. They were about to be mad because they said Bronemark will kill himself if see this, because it's not depending in the beginning on research, and that's it. So because and we are in the International Association for Dental Research, this is what I should ask this question. We are not in the Digital Dental Society conference, so I think we should reinforce depending our work to research and to clinical evidence. But it's not a criticism. I'm really impressed about what you are doing.
Well, I think the theme of this conference is innovation, and I think all innovations are initially not supported by the literature, and I do agree, and I kept on highlighting the importance of, before implementing this into your daily clinical practice, we need more evidence, we need more support. I have the luxury of working in an academic institution where I have the luxury of testing innovations like the ones I presented, and they are trending. They are trending in the literature now. We do see some early evidence and signs of evidence supporting those techniques, and this is what innovation is all about. Otherwise, it wouldn't have been called innovation.
Because of the time, I should close the discussion. And on behalf of the organizing committee, Dr. Fawaz, I'd like to present this certificate of appreciation. Because he is Dr. Zuhair, there is an exception always.
Thank you, Dr. Mashari. I agree with you regarding the points of evidence base. However, I think what Dr. Fawaz trying to do is open a new area of research as well. That's what he's trying also. Let's see the point from other view. He's trying to find a new era that is promising in research in the future. So I think that's what also maybe Dr. Fawaz is trying to do out of the IADR, not focusing mainly on the level of evidence, rather than say, okay, this is going to be a trend in the future, just be aware of it. Thank you.
Thank you very much. Again, Dr. Fawaz, thank you very much. Let's move on for the second presenter today. She is Dr. Ala Husni Yusuf Gari. She's from my home city, Mecca. I have the honor to introduce her today to you. Dr. Ala got her bachelor degree from King Abdulaziz University, and she completed a residency in geriatric dental medicine at Boston University, where she also received her doctoral degree in dental public health with a concentration in health communication and promotion in 2020. Dr. Ala is an award-winning international leader and entrepreneur in teledentistry, which is very exciting topic actually, Doctora, and public health. She leads various projects locally and internationally to advance the dental field and improve dental care access for patients in Saudi Arabia. Dr. Ala is an assistant professor of dental public health and an expert in teledentistry, intervention planning and applying users-centered design principles in developing health technologies. She is a teledentistry unit chair at Al Qura University, Mecca, Saudi Arabia, and she is also the co-chair of the International Committee at the American Mobile and Teledentistry Alliance in the USA. Please welcome Dr. Ala to present his presentation, which is titled Telescreening Among School Children in Mecca City, a teledentistry model to implement in Saudi Arabia. Please welcome Dr. Ala.
Thank you, Doctor, and I'm so honored to join you all in this conference. Today, inshallah, I will share with you all about teledentistry as well. I will take you from the very first of my journey till today, inshallah, the project of telescreening among school children in Mecca City. Just I'd like to share some of my journey for the students residents in the room, how I ended up doing teledentistry and specializing in teledentistry. So I took my doctorate program in dental public health at Boston University, and I created my own path in my dissertation in assessing the quality of mobile dental app. My curiosity took me all the way in Boston, attending all the digital health conferences, taking a lot of courses about developing mobile apps from other schools as well, from Harvard University, from MIT, from the School Public Health. All of that came very nicely together, and I ended up with my dissertation in mobile apps and teledentistry. And then I took the geriatric dental medicine, and here I wanted to implement teledentistry as well for this population. As you see in this photo, so this is from the dental home care program. The medical team goes to homes and examine patients. Sometimes if there's a concern in their mouth, they take a photo and send it to us. So it's kind of form of teledentistry as well. This is the first National Mobile and Teledentistry Conference. I participated with my dissertation at then, and then I became a member with them, and then a co-chair of the International Committee of the American Mobile and Teledentistry Alliance. This is from the hackathons and the competitions abroad. So for all the students and residents in the room, just be initiative and participate in any kind of opportunity. You don't know how you will end up at the end. Just a disclosure, any kind of products, or I will just mention it for the sake of examples only. So first of all, if you want to think what kind of barriers to dental care access we have in Saudi Arabia. Here it's in Mecca City. I tried to search the dental clinic in Mecca. If you notice in the map, like most of the clinics are concentrated in one region, as you see in this photo. Another barrier could be also the mobility problems and the medical compromise that many older population have. These are some of the barriers: lack of perceived needs, transportation, and residence location. There's no dental insurance. Most of the time they pay out of the pocket. mobility challenges, and for sure, like the pandemic period that we all passed by. This can be solved by implementing digital health in the dental field for prevention and treatment and so on. So I'm gonna give you an idea of the teledentistry at the beginning to be on the same page. What do I mean by teledentistry? It's the use of information technology. It's electronic information, imaging, radiographs, and so on, and telecommunication. So it's either interactive audio, video, data communication, to transmit all of that to a consultant or the other kind of health provider for the purpose of dental care, consultation, and education. It comes with different forms. It's not only one form. It depends on the use case, the problem, the needs, and also the special characteristics of your population. So we have the synchronous, asynchronous, remote patient monitoring, and mobile healthcare services. As you see in this photo, this is from the Finger Lake Community Health Center in the US. They are using the synchronous modality of teledentistry. That means the live video conferencing. You see the dental hygienist is connecting with the pediatric dentist, and she's taking the photo of the child, mouth and teeth, and then doing this consultation remotely. Another form is the asynchronous teledentistry, أو طب الأسنان الغير متزامن. It doesn't happen at the same time. So we take all the records and store it in the secure platform, and then the dentist or the consultant can see it in another, in another day or in another time. And here, this is in a daycare center, so she's not a dental health professional. She got training to take the photos and then connect with the dentist. We have also the remote patient monitoring, which is you monitor the patient's status through special devices like the electric toothbrush maybe. It can collect all the data of the patient, how is the brushing behavior and so on, and the general dentist or the consultant can have a very good idea of that. There is also another use in the orthodontic specialty for before moving to the next Invisalign, for example, he's gonna check the alignment of the teeth remotely. Another form is the mobile healthcare services using the smartphone apps, as you see in this photo. And we have many examples of that, but these are the main forms. The most important thing about teledentistry, there should be the dentist or the consultant in this kind of flow, in this workflow. I think you heard a lot about different companies that just send the kit without any advice or any consultation from a specialist and consultant. This is not teledentistry, and this can cause harm to the patient. It can be applied in many things. Do you think it's only, do you think all the specialties can implement teledentistry? By raise of hand, who believe that teledentistry can be implemented in all the specialties? Okay, that's awesome. So the majority of the room believe that it can be implemented in the endodontics, restorative, and so on. It's one of the dental care delivery that really help in providing quality care. It's not replacing the in-person visit, which is very important to know. It just complements this whole service to give the best for your patient. It can be used for triage, clinical collaboration, screening for exam, education and training. For example, if a resident has a case and the patient is there, all the consultants from other specialties can join this kind of video conferencing and discuss the case of the patient in his presence. So all the players are there in this meeting. And of course, for public health prevention, and it plays a very important, significant role in prevention. In implementing teledentistry, we always go back to the concept of public health program planning. There should be a problem, the needs, who are the target population, what are objectives, and how can we measure the success. So when you implement teledentistry, you should think of the interaction. Who are the providers? You can connect provider to provider, patient to provider. Could be a dental professional or non-dental professional as well. Could be with different devices, very simple device to very advanced device. Again, it depends on the needs and the problem that you are solving for your population. The modalities as well, it varies, as I mentioned. And then the patient location. The patient could be at home, at schools, at a different clinic, in a primary care clinic. It's very, very flexible modality. If you want to learn more about teledentistry, this is just a brief, just to be on the same page when I talk about the different modalities in the telescreening at schools. You can scan this barcode and you can learn a lot in this video where I explain with other different cases. So this is the announcement that we launched about the telescreening at schools. مبادرة صحتي في مدرستي لمدارس مكة المكرمة. We covered 10 schools from different regions to have this representative and to have the recommendations, inshallah, after finishing this project. We partnership with different entities, with Mecca Health Cluster, and also with non-profit organization, Dirham Wuqaya organization. And this partnership also has its own story. And I started this since I came back from the US in September 2020. Was amid of the COVID. So this is in the media. We just finished the visits just 2 weeks before this conference. Successfully finished all the 10 visits of the schools. We targeted patients aged 12 to 13 years old, and we used the IADR system in that, not the DMFT of the WHO. So I give you the final kind of story, but let's go back, maybe 2 years back, to give you an idea how this all came together. So when I came back in 2020, I wanted to implement teledentistry in Saudi. And to do that, I needed to connect with all my friends and colleagues who I met abroad. So you see Dr. Nicholas here. Also, Dr. Scott Howell, and this, the team from the Finger Lake Community Health Center. I learned from their program, the teledentistry for pediatric dentistry. It's so important when you implement any program, despite teledentistry, that you base that on evidence-based program, on successful programs. You don't want to reinvent the wheels, okay? So my meeting with Dr. Scott Howe helped me a lot in developing the curriculum and the content to train my team. And this is the story that I will share with you. So I established the teledentistry unit in January 2021. And the teledentistry unit aligned with the vision of Saudi 2030. The implementation of teledentistry can improve the healthcare services, can develop the e-government, and improve the quality of services provided to our citizens. So the journey of teledentistry, it has these 3 main components. It's focused on education and awareness, students, interns, faculty, and also doing research and pilot project. As we know, there's no like projects implemented yet in Saudi. So it's so important to start with a pilot to see how the implementation of teledentistry is unique with our population. Are they accepting that? Do we need to adapt it, customize it? So this is why we added this component. And then we have the patient care and community service. So regarding education, as the latest report from IADR, it's so important to include this new trends and new advanced dental care to the training of dental students and interns, just to implement that in the future, inshallah. So in the teledentistry unit, we give lecture series, discussions, training on practical implications of teledentistry. We use different devices. Thankful to the connection that I started from abroad. We have this in the lab, in the Phantom Lab. We collaborated also with the schools for the telescreening project. We started with 4th year till 6th year, as well as the interns. So the interns, the team who are with me now in the telescreening, they started this journey with me 2 years ago. In the education and awareness, we focus on different things about case discussions. We discussed successful programs abroad. We did critical thinking together, activities, group work. We also designed teledentistry programs together. Just imagine this background with my team. First, the case discussion. One of the programs that we discussed with the students is Dr. Nicholas' program in France that started 2014. It's implement teledentistry in nursing homes, and I'm going to show you the video. EDENT program. Oh. Can you play the video, please? If you click on it. Yes. So here's the nurses, as you see, and in this program they use the intraoral camera to connect the nursing homes with the hospital in Montpellier. As you see here, the patient. And the nurses got a special training how to use the intraoral camera and take all the views of the teeth. And this is what we talked about in yesterday's workshop. I'm not sure if some of you attended the workshop with me. Training is so important and significant in any program. So first of all, the visit, where they discuss with the patient, take all the photos, and then transmit that through a secured platform to the hospital. In the hospital, Dr. Nicholas and the team, they do the diagnosis remotely and the plan for the patient, and then they also can have hygiene care at their place. The beauty of this is that the patients already in their own places, they are so comfortable. They know the provider without the burden of just going to the dentist, the dental clinic, and just meeting someone new. As you know, these patients, this age is very vulnerable, and most of them may be having Alzheimer's disease and different kind of conditions. So it's so important to have this like in their place. Okay. We can go to the next one. So this is some of the cases that we discussed with my team, with my students and interns. Then we had this activity to design teledentistry programs together based on public health concepts and the use of logic model, just to have a sustainable programs. So one of the things that we did in our activities, we used also the zone of proximal development, and if we are talking about education here, we give tasks and activities to the students. It's so important, it's not that easy for them to solve, and it's not that difficult that they will not be able to solve it. It should have some challenge in the task, and let them think and try to solve the problem and come up with a creative idea. And they surprised me. I will show you. So one of the activities we did, just imagine you are conducting a media campaign on Twitter to spread the awareness about teledentistry. But here's the trick. Your audience is policymakers or public. You should customize your message according to your audience. So this is one of the answers that I'd like to show you. Okay, you can play the video, please. They use Twitter, Snapchat, all different media. There's no sound? This is for the 4th year dental students. And I asked them just to write tweets, and they come up with this creative medium for this activity. The last thing that we did in this kind of education of the unit is designing teledentistry program. We need to design it together. So I give them those concepts and how to critically think about teledentistry program or any public health program. It's the same principles. So we divide them into 2 different groups. Each group will focus on a different population, on geriatric, children in Mecca schools, and this is what we are in today, and the families living in rural areas. And we emphasize the importance of going back to evidence-based program and research papers as well. These are the concepts that we focused on. And then we used also the logic model. If you can play the video, please. The beauty of this journey, again, with the students and intern, it's established the connection with them, and they become very interested in implementing teledentistry, and they saw the meaning, the impact of implementing that. Just imagine having this theoretically, and then critically thinking about it, and then implementing that on the ground. It's a very nice educational experience for the trainees. We also, within the teledentistry unit, we gave free access and tickets to the National Mobile and Teledentistry Conference that was open to the faculty and students to just learn from other programs globally and connect also with them. So this is one of the group programs. They come up with this teledentistry program for children in Mecca schools. It's like a mobile app, and they followed the principles, and they did the whole program here. This is another thing. How is the workflow? It's so important when you want to implement a digital health intervention. Just imagine the patient from A to Z. How do you imagine the patient starting this journey and then going to who is the next provider till the end to complete the loop of treatment? You don't just implement digital health and you give remote consultation and leave the patient by himself. You should close this loop. So this is the education and awareness that I just covered. Then we'll go to the research and pilot projects. Oh, still we are here. Yes, there is also another module that we give to the 6th year students, which is a 4-week module in teledentistry. This is the focus more in the practical implementation in the Phantom Lab, and you can play the video as well. They were exposed to different devices, intraoral camera, blades and smartphones, secured platform. How can we conduct a virtual consult? And what are the ethical considerations also of delivering teledentistry services, including the consent form? So we covered so many important principles in that. And we started hospital rotations with the pilot that we run also in the hospital. So this is from the collaboration to develop the curriculum of teledentistry with the University in Arizona School of Dentistry and Oral Health with my colleague, Dr. Scott Howe. The achievement and all the projects were acknowledged in the American Mobile and Teledentistry Alliance report, and you can check that and read more about it. This is some of the feedback of the students and trainees that they are more confident now to identify the problems and refer to evidence-based, to describe modalities of teledentistry, and there's around 70% who are likely to use teledentistry after graduation. And the beauty also of this kind of programs and activities, they had a sense of the significance of public health and community health, which it's mostly forgotten sometimes. Most of the students focus on clinical aspect rather than public health aspect. So this is some of their feedback. They are curious about public health. They want to share this knowledge. They want to educate the community as well. It's a new experience. They really enjoyed this educational experience. So now I'll take you to the research and pilot project. And in these projects that we did, we built on it for the school-based program. We applied for grants, and we translate the research into the hospital and community workflow. So this is one of the outcomes of this pilot project. One of the projects is to compare like the accuracy of the in-person visits versus the telescreening visit. And the students who are working on this 6th year, now they're interns with me in the school project, they come up with a pamphlet to give instruction to the patients how to take photos of their mouth and teeth. And this was based on Arizona. Arizona school has many photos. We tried this first with the patient, and this is the beauty of participatory kind of research. We customize it to have this end result. We did calibration also with the students on IADR system, with collaboration also with the University of Western Australia, who's also one of our team members in this project. You can play the video.
استخدام الهاتف في الجوال للتصوير. 2. التصوير يكون بمساعدة شخص آخر. 3. ضرورة التصوير باستخدام مصدر ضوئي جيد. 4. ضرورة اتباع الأمثلة الموجودة في الدليل الإرشادي. يمكنك استخدام فلاش جوال آخر كمصدر ضوء كما هو موضح في الفيديو.
After many trials and doing the pilot also with the patients. In this project, the photos that were taken by the patients had more sensitivity and specificity, surprisingly, than the photos taken by the dentist. Okay. This is from the other pilot with Dr. Muhammad Al-Harthi in his clinic, the TMD clinic. So we did a virtual follow-up visits, and we checked the patient experience of the TMD virtual visit, virtual versus conventional. And we saw it's like similar. That means that quality services can be provided the same as in the conventional visits. So this is the other project as well. Regarding patient care and community service, we had the consent, we had the training and calibration, and now I can say we are ready to implement teledentistry on the ground for the schools. So this is the project of telescreening. We were selected as one of the 20 projects in Saudi to win this Digital Innovation Award. So this grant, بوابة مكة رقمية للبحث والابتكار, this the whole workflow of the project, as you see here. We train the school nurses, as the new model, inshallah, in the schools will be a nurse in each school. And then the school nurses can take photos of the mouth and teeth, transmit that through a secured platform to the university hospital, where the dentist can provide the screening remotely and provide the schools with the treatment recommendations for the kids. For this project, we have also in-person screening, just to compare both modalities as well. So first of all, we have the mobile clinic at the school. And this is from the reports of the mobile clinic. There is a high prevalence of dental caries, as you see, and it's well known, like above 90%. But among all of the kids, like for the 3 years with the mobile clinic, 74% of them never visited a dentist. And that's a huge, huge problem. So we focus in the telescreening on the early detection, and this is one of the preventive way, as you know. And this is from the recommendations of the mobile clinic. First of all, we developed the photography protocol, as you see here in this photo. We had many sessions just to come up with the best way to hold the smartphone and have a very clear views of all the teeth. So we first train all the interns, and then this is the team. We had dental interns, 2 school nurses from the Mecca Health Cluster, dental recorders, as well as supervisors from the college, and volunteers from our partnership with a nonprofit organization. First of all, we did a pilot visit of the whole workflow, just to know how is the acceptance of the kids, how is the logistic of the school, and all of that. And we customize everything accordingly. To train the school nurses before going directly to them, we did a mock-up training. We invited one of the staff with no dental background. She has a nutrition background. And then we give her the basic information about the teeth and all of that. And we trained her how she can take photo. And it ended up very nicely, and she did this perfectly, just after 10 minutes of the instruction. When we were sure that everything went well with our content to educate the school nurses, we invited the school nurses into 3-day sessions of workshop. The basic information we give is the teeth, just to know about that, the eruption of teeth, primary versus permanent, the dental diseases, how caries can happen for the kids, and their important role in early detection. It's so important that your members know what is the vision of the project, just to continue with you and be motivated, and they will end up champion for the role as well. So this was in the Phantom Lab. We showed them a demo. So the training the interns, it was like training the trainers for them. So it was really helpful to train the school nurses as well. I think there's the video, the next one. Yep. So we took them step by step in each view, and they practiced that in the Phantom Lab after the demonstration on the interns, on each other. This was in the Phantom Lab, and after they practiced everything in the Phantom Lab, they practiced on patients. We started with a very, as you see, messy posters. After the training with the school nurses, they took these photos themselves, and we used their photos in customization of a unique poster for them. And even, the order of the photos and the views, we change it according to their feedback, so everything is really clear. So here's the poster after all this feedback and all that training. This is the one that we printed in all the school visits. Designed by my young sister, by the way. So we had another training session beside the school nurses with the dental interns. We did a lot of calibration, a lot of practice, how to use the ICDAS, and we chose the ICDAS instead of the DMFT to show the severity of the dental diseases. It's really nice to locate the resources accordingly. Is it urgent? Is it routine dental care or not? It's more efficient. So we have, with our same team member and the partnership with the University of Western Australia, we did the calibration, we have the quizzes, and we check also the interreliability and intra-reliability for the trainees. We included as well the hypomineralization, the developmental defect. We included malalignment, and we were surprised that many kids needed urgent ortho care. And you know that usually in the screening, the focus is only on dental caries. This one is from the practice session on ICDAS. Yes. So we had also in our team the pediatric consultant as well as the orthodontist, Dr. Ibrahim Bamaga as well. And what's really nice is like the team were very motivated. It's a very nice educational experience for them. They were into that from A to Z. Here also a view of that training and calibration with all the team. And even, I didn't mention, okay. The team members is not only from Saudi, we have also from Dubai, we have from Australia, from Sweden for this project. From Dubai, our team member, she's directing school-based programs over there. And the beauty of this partnership is that we adapted the screening forms from them, and then we customize it to our project. So this is from our visit to the schools. This is one of the schools. As you see here, some of the schools had many challenges just to reach the school, and I don't think the mobile clinic can go to that place. Here at the school itself, oops. There's some schools had a very nice setup, some schools are not. But the logistics by itself, we had at the same day one school for the boys and one school for the girls. And from the volunteers, we have different specialities as well. Dental students, 6th-year students, interns, public health, nursing, all were volunteering in that. And the importance of having these different specialities when we were filling the forms, having, for example, a background in public health, they were so attentive if there is any kind of issues with the coding, with the filling of the papers, so it was really helpful to have them also in the team. This also from the screening at the schools, from the boys' schools and the girls. This is the whole workflow as you see here in this video. the school nurse, and here's the interns who started the journey, as you remember, from the education, the courses, and all of that. All of them were calibrated and trained, and each time they go to the school, we meet together and then reflect on this experience. And that's so also for the faculty, the reflection and the peer learning, really it's an educational experience by itself. Here, like each day after we finish the visits, we meet together and then we reflect on, when we reflect on what happened at the schools. They have a very nice feedback. They share with me the different conditions that they saw with the mouth and teeth, the behavior, the different behavior of the kids. Subhanallah, each region has their own behavior. Some kids were so friendly, some schools were chaos, and it was like training leaders as well in public health. Because we assigned a leader from the male team and a leader from the female team in each school, so they felt the sense of responsibility as well, and how to react and do the things if something urgent happened. So this is from our meeting. And this is at the end, after finishing this first stage of the school visit, 10 schools, alhamdulillah, almost we examined 340 students from male and female, and inshallah the next stage will be the remote screening and then the data analysis and collection and so on. But I'm so happy, as you see here, happy as my teams. We really connected and engaged in this citywide project, and we are open now for the question and answer if you have any question, and I can discuss this further also with you. Thank you.
Thank you very much, Dr. Ala. Very nice presentation. I will just open floor for discussion. Any question for Dr. Ala?
Yes.
Thank you for your informative lecture. I would like to ask, if the patient is coming for our clinic for treatment eventually, and we will need to examine him and take X-rays, how teledentistry is important? Although it needs a lot of training and time, eventually he will come and we need to take an X-ray and see him and screen his oral mouth. Thank you.
If I understood your question correctly, so we use teledentistry here for screening. As you see, we used a very simple device. If I go up to diagnosis, I would include a portable X-ray machine. I would include an advanced intraoral camera as the one used in France with fluorescence to show the caries and so on. So this is only for the sake of the screening. And we found actually by using ICDAS, it's really we can really see the severity also of the disease, and it was really helpful. After all that training, 1 minute we see the kid, oh, he needs really urgent care. So it's a better and efficient relocation of these services. So the use of equipment and devices, it depends really on your objectives and the needs that you want. The other consideration I took is there are non-dental professionals, they are school nurses. We want the simplest form from them. So it's very easy to learn how to take the photos using the simple device. And they started by taking photos in 10 minutes. With all of that, they ended up in 2-3 minutes. They took the photos. Just imagine that. Another thing that I'd like to share, when we went to the school visit, we saw the two modalities in front of us and the differences between them. We saw the conventional screening versus the telescreening, which is taking the photos. Here it's a lot of waste. Here it's just gloves and blade, and it's biodegradable and that you can recycle it, so it's environmentally safe. So we saw the two differences. The other difference came from the feedback of the participants. the interns were sharing, oh, Dr. Ala, I think the teledentistry will be better than us, and they will examine the teeth really and give the accurate kind of recommendations. Because we faced many problems, it's really hard to sit on these chairs. It's so painful, and also the visibility is not that good. There's some limitation with the conventional kind of screening, and it depends on from school to another school.
Thank you. We have another question, Prof, please.
Thank you, Dr. Ala, for your nice presentation. I would like to ask about the jig you attach it to the mobile. Is it disposable, or how you can get it?
The device itself, the perfume?
Yeah, for the mobile phones, for the lightning.
Oh yes. So this, it's like a phone and with attachments, and we attach it with a blade. And this kind of device, it gives the lighting for all the mouth and teeth. We only change the blade. This is the one, just we wipe it with alcohol swab, and then we put it for recycling. I'm not sure if I answered your question.
Yes, thank you very much.
But I'm so happy to have you here, Dr. Muhammad. Prof. Muhammad, he's my professor since I was in the college as a student, and he was the first doctor who supported me in my crazy projects at then. But subhanAllah, it made a lot of difference in my journey. Thank you so much, Prof. Muhammad.
Actually, I'm very proud of you always, Dr. Ala. Thank you.
You're welcome.
Thank you, Prof. Any questions?
You may ask anything about public health, education, and so on. Also, the people who joined us in yesterday's workshop.
Actually, Doctora, this is what we need exactly. Really, in Saudi Arabia, not only in Mecca. We need such program to be implemented for the whole kingdom, and also for the whole Middle East. And we know the prevalence of dental care is. How is it in Saudi Arabia and in the Middle East and in Arab countries? And we have shortage in clinics, and I mean, if you reach easily by those, I mean, those living in villages and outside, and easily to the doctors where to diagnose and to make it easy for them. I think this must be reorganized through you with Ministry of Health, which is very important. I see Tajamma, they are with you, right?
So this is the purpose of having this partnership with the Mecca Health Cluster, is to have this pilot within the Ministry of Health. So inshallah, like when they see that's really successful, already you have everything in your hand. We train your school nurses, so they will be the champion. They will talk about it, and they already talk about it. And also they can train the next school nurses. They actually go in another campaign with the Ministry of Health, with the Health Cluster. It's called the Fahs al-Istikshafi, or a screening or examination at schools. They do different things, but it's kind of like just asking the students, do you have caries, yes or no, something. It's kind of, it has its own limitation. After we did this kind of school visits, the school nurse told me, Dr. Ala, can we continue, please? I want to continue, I love this, and I saw the impact of it. I want to continue doing this work. Inshallah, we will have these recommendations, and it's already having this impact. We received also feedback from the students, from the school teachers, especially health coach or مرشدة الصحة المدرسية. They came and say, oh, that's really important. This is the first time someone came with this kind of innovative way of doing the screening. And for me, I can't do these things. It's really important to have a nurse to do this kind of tasks. And I see the kids are so happy. They want to take photos when they see their colleagues. Oh, my turn, please. I want to take photos as well. So the cooperation of the kids was really nice. Some kids actually came and hugged us, like each one of us. It was so touchable for all the team members that we have. Usually we are like over 20 in each day, in each of these schools.
I'm happy that you are happy.
Huh?
I'm happy that I feel that you are very happy,
Yes.
but you need to connect strongly with Saudi Dental Society, with Ministry of Health, with all the
Yeah.
university. We make a program. Now
Mhm.
FDI is here. Chair of Public Health is sitting just here.
Yeah.
So I think you should do something more.
This is the purpose
broad
of this
and-
conference.
And you
Yes.
just started now.
I
Thank
want to
you.
add something about the partnership. Like, for example, the grants that we had, it's kind of limited grants. You know, with the partnership, it's really, it added a lot. So we have these resources from the healthcare clusters. We have all the supply that we wanted. And from the nonprofit organizations, we were surprised with the number of volunteers. They started at the beginning with us. And the first days when they saw the impact, they said, please, doctor, take our numbers. We are with you. We are going to continue. I want to emphasize this, very important for the residents and trainee, the connection, the team, all of that. It can start from your classes sometimes, from these small projects, and can go in a national or citywide.
We have another
project.
question here,
Yes.
please.
Yeah, I'm Professor Latif from Tunisia. You're a really cheering person. I love you. Smiling and the presenter your
Thank you so much.
excellent conference. So yeah, as it said, you have to, I think, involve your projects globally. You know, I want not with WHO vision. You know, and it's really interesting because I think you are all becoming teledentistry dependent, and I think that the pandemic, COVID-19 pandemic accelerates significantly the use of digital means and teledentistry. So I think that which is very interesting and sad that this teledentistry, I think, will reduce inequalities, and you have given examples for that. Sorry. And this is very important that we have to reach by e-health and e-oral health, reducing inequalities and accessing regions that are inaccessible, and people like elderly people and people with disabilities. This is very important. And I do hope that there will be studies on the influence and the impact of teledentistry in reducing inequalities according to WHO vision, of course, and raise the awareness of people about people's well-being. This is very important. Thank you really for your intervention, that you have pinpointed this interesting subject. Thank you very much.
Yeah, thank you so much for the note. And it really starts also, I can emphasize more and more about the connection, the partnership, the collaboration, the beauty of this collaboration. Just to add, one of the partnership with the nonprofit organization, IADR AMER, we started this when I came first to the college with Dr. Mohammed Al-Harthi. I consider him as a brother mentor. We started this working on this partnership for a year, and then subhanallah, we activated this workshop, this partnership for this specific project. Just something like to share with you all, like just these small things, it will make really a huge difference. Thank you so much for
Thank you.
joining us today.
Thank you, Dr. Ala. Very nice presentation and discussion. We would like to take time now to present you this certificate on behalf of the organizing committee. Please, thank you. We will be here back 1:30, inshallah, to continue our scientific program.
Good day, colleagues. I greet you with the universal greeting of peace, and I wish you all the success with this conference. I thank the organizers.
Okay, good afternoon and welcome back. It is our pleasure and privilege to welcome the moderator of our second session, the respected Dr. Saylan. She is also the Vice President of the Saudi Dental Society and a member of the Science Committee with the FDI in Geneva. She is a consultant of oral and maxillofacial surgery at King Abdulaziz University, Jeddah, Saudi Arabia. She has also attained a PhD from the College of London in 2005 and a fellowship from the Royal College of Surgeons. Without further ado, please join us, Dr. Hassan.
Assalamu alaikum. We need more audience. Come on, guys. Fill in the hall, please. I would like to introduce, we have 3 speakers for the session. Our first speaker is Dr. Zuhair Nettu. Dr. Zuhair is an associate professor in public health at King Abdulaziz University, as well as Harvard University and Taft University. And he's a consultant periodontic and implant dentistry and consultant in public health. He earned his Diplomat of American Board Periodontology implant board as well, and he published 85 papers, and he earned and got 65 awards from different part of the world. Please welcome Dr. Zuhair.
Okay, Assalamu alaikum. Thank you, Dr. Samira, for introductions. So, title of my presentation is let's move to the next step. Increase the citations, number of citations. First, I'm going to talk about several website programs. I want to tell you, I don't have any kind of conflict of interest with them. I don't work with them. I will not get any percentage out of them. It's just to share some knowledge with you. So what I'm going to cover today, I'm going to see what our current status, then we're going to know what we can do to promote our research, which is our main bulk for today. So what is our current status? If we look to the all articles in all fields for the paper published from 1996 to 2021, 25 years, we're going to see regarding number of the articles, United States, China, Europe. Then you're going to see the first Middle East and Africa country is Turkey in the position of 20. Okay. Then Iran, 21. Then South Africa in the 35. If we look again, then we have Egypt, 36, Saudi Arabia, 38. This is the list. Now, if we look to the number of citations per document, we're going to see the same, almost the same figures. We see the Middle East and Africa come more toward the end of that list. Okay, this is regarding all fields. What about articles in medicine only? Now we are focusing, since we are here in medicine, let's see medicine only. How are we doing as Africa and Middle East? If we look to the number of articles again, we're going to see most of the Asia and Europe countries. Then we're going to see first Middle East country, Turkey in the 15th positions. Then we have Iran in the 21 positions. If we look to the citation per documents, so we are doing much better with the number of documents compared with the all field. We're going to see we are much lower in that list. You're going to see the first Middle East country or Africa is Zambia, Uganda, Tanzania, Malawi, in that list. So we are more than the 30th positions. Now let's focus on dentistry. So we start to move from all field to dentistry. We see when we come to medicine, we're doing much better. Now let's see with the dentistry. We're doing much and much better. Let's see how our result. If we look to the top 10 list regarding number of documents, you're going to see Turkey in the 9th positions. Then you're going to see Iran in the 17th and Saudi Arabia in the 18th. This is in dentistry. All the paper published in dentistry in the 25 years. When we look to the number of citations per documents, we're doing not that much. You're going to see here the first country is Turkey in the 23rd positions. And then we have Egypt in the 26th, Iran 27, and Saudi Arabia in the 28th. Now let's look to each area in specific, since we are AMER conference. So let's look to the Middle East, which the top country publishing in dentistry. You're going to find in 2021, Saudi Arabia come at the first, followed by Turkey and Iran. And if you look to the past 10 years, you see the competition is between those countries. Again, Saudi Arabia, Turkey and Iran, those in the 2019, you're going to go back to 2017, Turkey, Iran, Saudi Arabia. So there is always competition between those three countries, and Egypt comes as the fourth countries. When we look to the Africa, there is another competitions. You're going to see Egypt, South Africa, and Nigeria. This is the competition in Africa. And Egypt always the first, mashallah, and always the competition between South Africa and Nigeria regarding the second positions between South Africa and Nigeria. Okay, so now we look by countries. Now let's look by regions. Again, we are in the AMERS conference. Let's look by regions, how we're doing as Africa and Middle East. So this is the regions, Africa and Asia and all those regions. I compare here for the last 10 years, 2011, 2016, and 2021, regarding number of documents. So we can see, regarding number of documents here, we are as Middle East in the 5th position, and Africa in the 8th. The same figure again, you'll see it in 2016 and in 2021. Okay, now let's play with the data. Let's combine Africa and Middle East. Let's call it AMER, okay? Let's see if this figure will be changed. Again, we see the same figures again. We are in the 5th positions. However, we moved here to 2021 to the 4th positions. And here you can see there is increasing in the trend when we look to the, sorry, let's go back, to the trend when we look into the AMERs at the whole regions. Now, let's look to the number of citations. Number of citations is much less. We see again in the Middle East, we are in the 5th positions, 2011 and 2016. It didn't change, and Africa became the last one with the number of citations. And the same figures if you combined Africa with the Middle East. It didn't change that much. And you can see with the 2021, there is a decreasing in that one, so I will not use this one for analysis, just focus on 2016 and 2011. So when we look to the citation per document, we are in the 4th position 2011 and 5th positions in 2016. So let's summarize the first part, what I want to say. First part say regarding number of documents, we are among the top 3. I'm fine with that. In the Research World Cup, we got the 3rd place and the bronze medal. I'm okay with that. However, when we look to the number of citations, we are in the 5th positions. When we look to the number of citations per document, we are in the 4th or between 4th and 5th position. It means we lost the semifinal. Okay, so we are out of the competitions from the top 3. So why we have good number of publications, but we don't have good number of citations? Well, there are several reasons for that. It could be due to quality of the research, could be due to the teams that we have, could be due to the material methods we use, or could be due to the promotions. Regarding the quality of research, team, materials, this is usually a workshop. I give it take around 6 hours, how to target ISI journals and what we can do for the quality. So let's assume here all the people, and I'm sure all the people here doing good science, So we have good quality, good team, good material. So what we can do regarding the promotions. So now what we can do to promote our research, and this is our main topic. So why we need to promote? We need to promote because a good research has the power to change everything if successfully communicated. So what we mean by successfully communicated? It means it communicates online or in person. It happens between you and journalists or within scientific community or to the relevant policymakers or practitioners or between you and the wide public. So who knows who is this guy? Anyone know or recognize? Okay, 1, 2. So this is Professor Mahmoud Turbanjat. How many of you heard this name? Turbanjat. Okay, I see some hands, about 25th. Okay, perfect. So Professor Mahmoud Turbanjat, he published more than 200 articles. He has 35 book and book chapters, tons of patents. He competes with you, Professor Leila. Tons of patents, okay? And he is the one behind MTA, mineral trioxide aggregate. So whenever he publishes any paper, he doesn't need to promote. Why? Because the people will talk about his article in the conference. He can talk about his article in his lectures. The schools and postgraduate program will teach his result. And the dentist will use the result of his articles in the daily clinic. So he doesn't need to promote. His name is enough, okay? However, Professor or Dr. X is very nice doctors. He published nice paper. How many of you know Dr. X? You know him? Okay, 2 you know him? Perfect. So he published very nice articles and very nice, however, he did not promote his articles. How many of you know about his articles? He's a very nice guy, he's very nice paper, nobody knows it. I think most of us, except maybe the first 3 lines, like Professor Turbanjat, we are like Dr. X, except those in the first line. Oh, Dr. X, okay. So all of us like Dr. X. We need to promote our research. We need to promote it, okay? Because I need to be like Professor Turbanjat after 20 years. I need to work hard. I'm not yet there. And I think most of us like this, so we need to promote our research. So what we can do? So first things come to your mind, submit your articles to the highest impact factor. Yes, go ahead. Whenever you have any manuscript, select the highest impact factor in your field. If it's accepted, perfect. What happens if it didn't accept it? It's going to be rejected. Sometimes they're going to give you comment. You can take this comment and you can go to other journals or the same journals, it's okay. Or sometimes you can know this is not the type of the articles that this journal can accept, so maybe I can try other journals. So always try the highest impact factor. There is nothing to lose, okay? However, there is a learning curve. You have to be patient. You cannot get those journals from the first. I have so far, alhamdulillah, mashallah, 86 articles. However, 2022, I was able to publish in Lancet. It took from me a while. It took to me, I cannot tell you how many I tried, how many I rejected, but at the end, I got 6 papers, 2 in the main Lancet and 4 in the Lancet Public Health, Lancet Global Health, and Lancet Infectious Disease. So it took time. What is my next step? It's going to be Nature, Science, New England Journal of Medicine. How many years it will take? Maybe another 5 or 10 years. There is a learning curve, so you have to be patient. You're not going to get the highest impact factor from beginning. Okay, what if I couldn't get the highest impact factors? Is there anything I can do? Yes, you can do a lot of things. First things you can do, the keyword. What we can do with a keyword? Keyword is the tools that help indexers and search engine to find relevant papers. What that means, so if you make it easier, there is more people will access your articles and it's more likely to read it and they're going to cite your articles. So if I'm going to, anyone write these words in the search engine, he or she is supposed to reach to my articles. This is the idea of the keywords. So I put some words here. If anyone select one of those, he should pick these articles. If he uses one of my other articles here, he should reach to these articles. This is the idea of keyword. However, I used to do it with lousy way. Let's talk to you how you can do it with the correct way. Usually say we need between 3 to 10. I pick up the lowest 3 keywords and go with the minimum. Don't go with the minimum, go with the maximum, and I will tell you why. Okay, first things here to know about the keyword, something called SEO, Search Engine Optimizations. What search engine optimization is in the mind to make sure your article is discoverable by search engine. It means you're going to do search about what is the best keyword for my articles. How are you going to do that? You're going to have a list with the 15 to 20, okay? And then you're going to test those keywords. You're going to test these keywords in different search engines, PubMed, Web of Science, Google Scholars, and see if is the result going to be similar to your articles or not. This is, for example, the list. Once you're going to have the final list, you can use them. Not only that, use the keyword in the title. Try to use 1 or 2 keywords in your titles. If your title is too short, don't make your titles too long. Try to make it short as much as you can. If it's too long, then move it to the abstract. So I use some of the keyword before here in my titles. Then use the same keyword again in the abstract. Repeat 2 or 3 words 3 to 6 times. Not more than that. And only if it feels natural. Try to repeat the same keyword again and again 3 to 6 times. Not more than 6 times because you're going to end up with something called keyword stuffing. What is keyword stuffing? They used to be to do so to make my article show up in the PubMed. I will repeat the keywords 100 times in the abstract, for example. And this article will show up the first one. So now what the search engine will do, if you repeat the keyword too much, it will going to lower your articles in the search engine. So they know that. They know the trick. So don't go beyond 6, okay? So what we can do after that, you can repeat the keyword in the all fields, in heading, subheadings. So that will help also to identify your articles. And also use the same keywords. Don't change the keyword. Use the same terminology in all over your manuscript. Whenever you use the keyword, always think about your title and abstract. Because this is what they use in the search engine. So you have to have your keywords in the title and abstract. Some people would pick with the keyword, this is fine. This is another way, which is okay. Then another thing you can do, what we call it keyword phrases. Keywords shouldn't be only single words. Try to use phrase. So this will make easier for people to identify your articles. And you can read about this one, you can find many articles, so you can use it as 3 or 4 words rather than you have single one. Okay, I did the keyword. What can I do else? Well, they said you have to build inbound link for search engine optimization. What do I mean by that? Use your professional email. Because this is how the website will link between articles and you. Use your professional's educational email. They found if you're going to use .edu site is more highly valued by Google's. Okay? So try to use, whenever you have web page, you have your articles, don't use Hotmail or Yahoo. Use your educational emails. And try to find your articles as soon as you can in your home page in the university, for example, in this Harvard. So I keep adding those articles whenever it comes. If you remember the previous one, I have about 86. Here is about 80 because they couldn't find some of my emails. So you have to use the same educational professional emails. What you can do else? You can add the information in the Wikipedia and have your article as cited in the Wikipedia. What do you mean by that? For example, why Wikipedia? Wikipedia because most people are going to use information from Wikipedia. So if you have information related to your articles, for example, Corona, and then I found here there is information I can add, so you can add my articles, you can go to edit, and you're going to add this information and use your article as a reference. There is more people who read about your article and you're going to get more citations. What else? Use the social media, and I will talk today more about social media later on. However, with the social media, you can use it for the scientific community. You can use the social media for other things. This is not our topic. But for social media, you can use the LinkedIn, Facebook, Twitters, and I will talk about those in a few minutes later on. So now, whenever you're going to publish an article, like this article we try to publish in medicine, they will ask you, do you have a social media promotions? If you say yes, just put it. And once the article is published, it's automatically they're going to announce it in the Twitter website. For example, this article, when we publish it, they said, okay, what makes a smile attractive, blah, 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 this is Zuhair Netto. They're going to publish it automatically. Some of the journals will not going to do that. Like my articles here, when you publish with the Cochrane's, they're going to do it by themselves. I accidentally find they are the one who just announced this one, and they write very nice, briefly summary, and then just wrote our names as the co-author here. Or you can do it by yourself. Just write a small summary regarding this paper, which I did before, periodontal pocket and SARS-CoV, and sometimes you can get very good number of about 150,000 impressions. I got to this one, sorry, because this one is covering. So and you can get several retweet and like from the scientific community as well. And most of the journals now, whenever you publish any paper, they will give you a link and say, okay, share your article with this link. So if I click in Facebook, Twitter, or LinkedIn, it's going to show up something like this. Just I need to add my information here or whatever I want to say, and click. What can I do else? Make your work open as possible. And what I mean by that? There is two things you have to know about it: green open access and golden open access. So let's start with the green, start with the golden open access. What do we mean by that? Golden open access is once your paper is published. So everyone can download it and they can use the full manuscript. Green open access is your paper accepted, but it's not yet online. So you can publish this one in specific websites for about 12 months, 4 months, it depends on which journal you submit, until your full articles published online. So you can always do the green open access, but you have to double check. Gold open access, no, you have to most of the time pay for it. So for those who didn't get the green open access and who can do it, you can do it by yourself or through your university, okay? And to make your work freely available online. Most of the time, it's run by universities, like for example, Cornell University, Penn State. This is examples of websites they can accept, repository website, they can accept green open access. Gold open access, no, you're going to pay the ABC, article publication charge, and you can get the fund here from funding agency, from institutions, from society, or from you, okay? You can pay for that. What can I do also to increase citation of my articles? Data sharing. Make your data available. Make your data available. This will help people sometimes use your data. They're going to use your articles and they're going to cite it. So the first time I know about this one is these emails when I try to publish an article regarding to the COVID-19, and they asked me to make the data available and also to make something called preprint. I will talk about it in a few minutes. Then after that, I received these nice letters after I make my data published. I received this letter from Sichuan University from China. They asked my permission to use my data. I didn't know about Sichuan. All I know is Sichuan is nice Chinese food. Whenever I go to the Chinese restaurant, I usually order that. It's delicious, by the way. Chicken Sichuan. It's very nice. So I was worried. This is from China, and they asked my data to get permission to publish it. So I was investigating about these teams, who's these teams, and I found the PI in University of Qatar, and they are doing actually good work. And now we are processing to publish 3 papers together, and by sharing my data and using also my articles in their reference. So sometimes it can open citations, also collaborations between several scientists. So let me to go a little bit for those who not sure about the article's versions, we have the preprint, which is the submitted manuscript, not yet accepted. And we have the post-print. This is accepted, but not yet fully available online. There is no PDF. And we have the final versions. So you can publish also the preprint. There is websites that can help you to post the preprint. Let me give you examples. Since I don't want to run out of time, how are we doing with the time? Okay, I'll run out of time. Okay, regarding the preprint, there are some websites, for example, Midrechive. This is a website, collaboration between British Medical Journal and Yale University. So you can have it in this website, and they can even help you to transfer your manuscript to one of those journals. If you are not sure about what is the policy of the journals regarding the golden open access or green or data sharing, there is a website, some website online. You can click the name of the journals, and it will tell you what the journal's policy regarding those steps, or institutions, or funding agencies. So there is free or available online website. Then we're going to move now to the share of your work. And let's move quicker since I have only 15 minutes. And now we talk about social media. So usually try to create link, as I mentioned before. Whenever you publish any articles, try to email it to the research department that you have in the schools, or the vice dean of research in your institutions. Okay? For example, in Harvard, they have the research bulletins, so they can announce every 2 months what is the paper published in their university. In King Abdulaziz, we have the research news. It comes every 6 months. And it's slightly different, but we have also the research published article as well. This is based on the school level. We have in the university levels every month the report. And there is some schools, they have just articles on the board. Whatever they can do, that's good for you. Social website. One of the websites that good also to promote your research is the Facebook. Facebook, actually, they have author web page. And we saw this morning, Dr. Fawaz was talking about Dr. Panos Babasakridis. He used to be my mentor, and now he's my friend. He has very nice way always to publish a summary of his articles on Facebook. So you can he always make a summary of his articles, and you can see whatever he do, usually he publish it online. And you can see my names in some of those articles as well. So you have to decide which social media you're going to use. It's okay to use 1 or 2. You cannot be available in all of them, or you can alternate. If you're going to use the Facebook, for example, you can use the author page, so you can differentiate between your personal page and author page. Yes. Try to be visuals. Try to make figures, pictures, okay? And there are several ways how to make those figures. One of those ways is Canva. I used to have, for example, in my Facebook, only these pictures. This is my dad. Because I believe in, whenever I see my dad, I want to say, Allah yarhamaka ya waldi. Like if someone told me, when anyone doesn't know you, he will think this is you. So now I'm trying to combine both of them. However, it's okay if you're going to have some philosophy. And regarding the number of people who follow you, you have to decide, is it going to be personal or something for scientific? Because if scientific, maybe you have 50, 500, 1,000 is fine. But if you're going to go to the public, you need to have 100,000 followers or whatever. So you have to decide what is your target from your social media. This is Canva. It's a way to help you to make figures and diagrams for your social media. Try to create content schedules. So post every month or every 2 weeks, but please don't post every day. Even if you are very well publishing or very nice, because this is going to bother the others. So have schedules, but try to make it more like make sense for others. And try to change the type of posting. Sometimes you can share some news about your next conference or citations or whatever, or just maybe personal news regarding with a patient, sometimes. Don't use the same way always to post the information. Try to send these links to the groups and to the scientific groups and discussion on those social media. And now I will talk something very quickly about hashtag. So use the hashtag. This is one of the things that help to increase the citation of your article reading. Hashtag actually is like a terminology. So if I'm going to click in, for example, I use that hashtag for my article. So anyone click on that hashtag, he's supposed to be find my articles. So how I'm going to find the best hashtag for, by the way, you have to use only 1 to 2 hashtag. Article said if you're going to use 1 to 2 hashtag, it's going to increase engagement by 50%. If you use 3 or more, it's going to decrease by 17%. Just have to be aware about hashtag. There is a limit. 1 to 2 is fine. If you want to know what is the best hashtag for you, you can use, this is what they call it, hashtag 5. Okay, so it's going to tell you the best hashtag for you. Or you can use right tag. Right tag is going to analyze your previous post and going to tell you what is the best one based on the previous one. There is another thing called keyhole. The keyholes also is going to give you a snapshot for exactly how you're doing in the Twitter regarding certain time of certain hashtag. Some of the websites like ResearchGate and Academia, they will allow you to upload your full manuscript. However, you have to be careful. Whenever you upload the full manuscript, just check the policy, if you can upload that or not. There is some policy, you have to check for that. So this also will increase citations of your articles. There is something called blog. I will not talk about it. It's not common in our area. However, blog is like for non-academics. It's like abstract, small abstract, but it's written for non-academic. And this is very common outside in Europe and US. And you can find tons of hashtag. Let's go faster. How many minutes, Dr. Samir, I have? Okay. So another thing here, you can make a Google Scholars. I think most of you know what is the Google Scholars by now. I should go fast. Okay. Another thing here, you can go with a LinkedIn. LinkedIn, you can use it also as a part of information that can help you sometimes to make your science or your articles information available. So some tips for LinkedIn profile, profiles. Always you have to tell your story. So make like a small summary about yourself. Try always to have the newest one first, then the oldest one later on. Make it powerful and concise. You have to make it public. Highlight your work and also show your case and honors whenever you have. Add image video presentations. And one of the most important things, you have to add your ORG ID. Another thing that will help you to increase also citation of your articles is to talk about your research in your conference and become a master presenters. And this is very big topic. I will not go over it because this is not our focus today. So whenever you have any conference, just speak up about your result and try to be proud of it. Podcast is another thing. It's not common in our area, but it's a type of programs that is you're going to download this one and you're going to listen to it whenever it's available. So I want to listen to it now, I want to listen to it later on, so it's based on your choice. So you can make small podcasts, scientific podcasts. This also can help to increase citation of your articles. Kudos is one of the way that I'm going to make summary for your articles. So you're going to see most of the publisher here, Wiley, Seg here, they're going to make like a small summary and going to publish it on Kudos. Another thing here, you have to engage with the media. So whenever anyone asks you scientific questions, you have to go and respond to him. And then it's preferred to be within 24 hours. Use image as much as you can. You have to be realistic. Not every post you're going to get a response. Some of those posts, maybe some people will respond to you, some of them, no one, that's fine. Engage in the social media as I mentioned. And there is other things you can do it. You can use image and infographics. This is a new way now they're using a lot. Webinar and slide share. Now the people sharing their articles in the slide share. They make a summary and they're going to put it in slide share. And then we have the lay summary as well. Another thing here that can help you to increase citation is the front cover image. What I mean by front cover image here, the front cover image is the first image on the journals. Whenever you have any journal, there is an image. This can help the citation of your articles. And they found if there is an image for your articles, it will increase the full text view by 35%. First time, usually whenever you have any published articles, you will see a small comment in that accepted article say if you have figures that can be selected as a cover image. So you can communicate with them about that. And actually the first time it came to my attention when I published my paper in Journal of Clinical Periodontology, which was one of the highest impact journals in dentistry. And they said, we select one of the image in your articles to be in the front page. However, we need 1,400. So you have to pay for that. And they ask for 1,400. And actually in that time, and what you call it in Saudi, mutaffir. I'm just at the end of a scholarship, I want to go back home. So I don't have money to pay for the 1,400. However, there seems to be, they like it, and this is the figures, and then they have it on the front page of the journals. So people are paying for that one to get their figures in the first journals. Huh? No, I didn't pay. I want to leave me alone. I want to go back home. So one thing you have to know, whenever your cover image will be published, they're going to give you DOI, Digital Object Identifiers. So it's like publications. So whenever you're going to go to the Google Scholar, you're going to see my main manuscript, and you're going to find also the cover image as a separate DOI. Videos. Make a videos for your articles. This will help more people to read about your articles. And they found when you have a video, you're going to have 447 more in higher altimetric attention. We'll talk about this one in a few seconds. And 111 higher full text view. So how you can make videos? Okay, you can have the video in your manuscript. You can post it on the journals or publisher websites. And there are websites, actually we have graphical abstract as well. So you can publish your articles as the figures. These figures is from your articles or could be separate figures as well. And actually there are a website which can make it for you. For example, these publishers, you can see how much you can pay for that, or you can use the free available online or any other website to make the video for you. So once you're going to do all of that, you have to double check. How am I going to double check what I did so far? Is you're going to use altimetric or CODUS. So altimetric is the way that you're going to double check how you did so far. And we don't have time to talk about it. And there is other ways like CODUS, citations, and H-index. Always respond to comment, or whenever anyone asks you for a full text, try to give it to him. Sometimes you're going to get the request by emails. For example, one of my papers in social media, it keeps asking for the full survey. So you see people from Al Qura University, this is from Lima, Peru, Al Qura University, from Iran, from Jamiat Imam Abdurrahman. I always respond to them, and I'm going to give them the full survey. Don't forget, you have to be selective. Don't post everything, especially for the scientific community. Whenever you're going to talk to scientific community, you have to be selective to what you're going to post. So overall summary, set yourself for success. You have to have your org ID. Think about search engine optimizations. Use always your professional email. Make sure your work is open as much as you can by gold open access or green open access. And also don't forget to use the preprint, data sharing and preprint also. Share your work using the journal's website that they're going to give it to you, or through emails or media, whatever you have. Talk about your research in our conference, in seminars. Grab attention with great content through figures, videos, cover image, webinar, slide share, and check how you're doing through Altimetrics or any other website. So now I promote also, I have a YouTube channels, okay? So this is the YouTube channels, is I'm trying to explain all the research concepts. I'm keep adding this YouTube channels. So that's going to be my next goals. And thank you for listening.
Thank you. Thank you very much, Dr. Zuhair. Very nice tips for you guys. And you may keep your contacts, maybe the young one to contact you. Can we take a few questions, please, from the audience? Who wants to ask Dr. Zuhair? He said lots of nice tips. Nobody? Come on, young people.
Okay.
Someone ask.
Can old people talk or not only young people? Okay.
يلا. You are young, يلا. دكتورة إلهام تفضلي.
So thank you very much, Dr. Zuhair. I think we need to hire like a secretary for all those ideas just to promote our, because it takes time.
Yes.
Yes,
definitely.
I know. Okay. So I have certain points. Sorry, I can't like stand up. Okay, first for citation per paper for the numbers that you presented for the whole countries. I think sometimes the absolute numbers, are not fair to different countries. So I think indicators like citations per paper and maybe paper per faculty or per country, are more fair for those countries, because we know like some institutions they have 400 faculty and some institutions they have 2,000 faculty.
True.
So citation per paper, and I think at the Middle East and on the Arab countries we are doing very well on the citation per paper, which reflects the impact of the paper. And the thing that we are all going in the Arab world now for open access, so I can obviously see that the citation will increase in the coming 5 years, sorry. So this is one. The second one, do you recommend use the mesh keywords?
Okay.
Yeah. And the third point about preprints, because I was excited about preprint and I posted one of my articles preprint, and then I submitted to another journal, the editor was for oral epidemiology and community dentistry editor. They told me try not to publish it preprint.
Let him answer one by one, Dr. Ilham.
How many questions as well?
Okay, it's just about the preprint and
Let's
the
do
mesh
it one
work.
by one,
Thank
Dr.
you.
Ilham. Ask him the first question again, please.
No, that's first
Just the
question.
mesh
خلاص?
and the preprint.
Okay.
Regarding
Fine.
your first questions, I agree regarding the number of countries and institute, but that's what we use so far, so I'm trying to use whatever available. I don't agree with you regarding the second half that we are doing with a good number of citation. No. Most of the people are here in mind is like they want the research for promotion to their academic career, but not to promote the research for the scientific community, which is something different. So this is another thing we can talk about later on. Regarding MISH, it's up to the journals. If the journals ask about MISH, you have to follow MISH. But if the journal didn't ask about MISH, put whatever you can. If they want 10, put 20, okay? So try to use as much as you can of the keyword, because this is how the people can reach to your articles. So you want to have like 8 ways to reach to your articles at least, okay? So try to use as much as you can. And your last questions?
About the preprint.
So you say advisor didn't recommend it?
The editor of the oral epidemiology, they said like it is advised in general, not to share your article first in preprint before trying to submit it to journals.
If he said that's one to me, I say, okay, thank you, this is your opinion. That is his opinion.
What's your opinion about that?
No, my opinion, make it available as much as you can. I used to be like, worry about stalling my ideas and those people in the China and those stuff. No, but now I'm not thinking about that one anymore, okay? Because now they want to try to publish it, they will think about authenticate, and if I publish that one, they will be in big troubles. And I know some stories, even in our university, it happened. So be careful. I'm not worried about this one anymore.
Perfect. Thank you very much.
Thank you very much, Dr. Zuhair. And on the behalf of the organizing committee, we would like to thank you for contributing to the conference. Abdurrahman, give me the certificate. Thank you very much, Dr. Zuhair. coming to our next speaker. She is from South Africa. We have Dr. Sadiqa Khan. She has a PhD in community health, and she's an associate professor in the Department of Prosthodontic Dentistry, and she has so many areas of research, and she's an expert in systematic review, scoping review, and she contributes a lot in her research. Unfortunately, Dr. Sadiqa cannot be with us in presence, but she is with us online, so we may listen to her virtually. مع كوفيد وكورونا تعودنا صح نسمع بالزوم وكده, فبليز don't leave the room. Listen to Dr. Sadiqa. Thank you.
Good day, colleagues. I greet you with the universal greeting of peace, and I wish you all the success with this conference. I thank the organizers, the AMER Exco, the IADR KSA, for this opportunity to add to this conversation on research. I'm truly honored to be part of this conference, and I hope my small contribution will have a meaningful impact. I enjoy research, I enjoy conducting meaningful research, and I hope that I can share my experience and my passion with you. The topic of my presentation is Global Trends in Oral Health Research, which is largely in line with the theme of this conference. What I am going to explore and investigate is, are these trends appropriate and relevant for all contexts? And I'm speaking as someone coming from Africa, and my focus would largely be on research in Africa. For the outcomes of this paper, I'm hoping to share with you a few of my thoughts, and one of those would be to identify, inform, and understand the trends in research, and I might even speak to it as those trends in the first and third world countries. I'm also hoping to share with you certain approaches on how to do research differently, and lastly, the importance of collaborations in research, and I hope these will add meaningful contributions to your knowledge and understanding of research. And so yes, my focus would be on doing research differently, and of course, so too my presentation. So I'll start with my take-home message to you, and that would be, let's do research differently. And I will share with you what I mean when I say let's do research differently. Colleagues, I just thought I'll share this slide with you because I think we need to know what kind of research and how we need to address oral diseases within our field as researchers. This is oral disease data, not specific as such, but from the WHO Global Oral Health Report. It shows that oral diseases have remained the most dominant conditions globally since 1990. And these are broken down specifically into the different types of oral diseases, and I'll share that with you in the next slide. From this WHO Global Oral Health Report for 2022, oral diseases data available from this global burden of disease data set is broken down further into the major ones are the untreated caries of permanent teeth, which is the most prevalent, and they've recorded it as being 2 billion of the population. Severe periodontal disease, second, then untreated caries of deciduous teeth, and then lastly, edentulism. And if you look at this group of major oral diseases, it impacts on all the different age groups that is available. And that is a very scary thought, and I think when we focus on research, we really need to address some of these concerns. The current oral health trends in research in the first and third world countries. Oral health research, generally, these vary globally. Ideally, it's according to the need of the populations, of the communities, specifically where the researcher is, the demands and the context, and of course, most importantly, the resources. And that is not without any other issues as well that needs to be addressed. At times, third world researchers would like to follow research and do it according to the global trends, but whether that is appropriate for their specific context at that particular time is debatable. If you look at third world research, for example, in Africa, Africa has a particular burden of disease profile, and it may then direct the research to have a particular or very specific focus. And I always say this, African researchers should be driving this research because they understand the issues related to its context, they understand the population, they know the disease burden with its related challenges, and they know the access to their resources and the limitations involved better than anyone else. So oral health research in Africa, for me, should always be driven by Africans. And of course, I don't mean exclude third-party involvement. They can have a particular involvement, and we should be very specific about that involvement. And later on, I will speak about collaborations, and we will take it from there. If you just look at these little global pictures, the one on my left-hand side is about the epidemiology and the disease burden in Africa, and it's a report by the WHO. And if you look at where the most of the issues are, and it's mostly in Africa and some areas of the East and the Far East. But if you look on my right, and here it was taken from how many, they speak specifically about malaria and malarial deaths, and where the largest burden would be in Africa. But if you add, this is this pink area over here. But if you look at the number of physicians available for the people in Africa, it's too limited, it's too few. If you go further down and you look at the researchers available in Africa, also too few. And I'm sure similarly, we could have the same kind of plotting for oral health issues, oral health disease, the oral health practitioners, as well as oral health researchers, and the limitations there, and the limitations of the number of these available. I'm particularly curious about these two pictures. On my left is a WHO report that speaks about the epidemiology and disease burden in Africa. And if you look at the areas that are darkly colored, it's mostly within Africa and the Far East. If you look at the picture on the right, and this is an example of malarial deaths in Africa, and most of it is in Africa. But if you look at the number of physicians available, it's too few available. If you look at the number of researchers available, it's also too few for the disease burden. I'm sure if you look at oral health diseases, oral health practitioners, and oral health researchers, we probably would have exactly the same kind of plotting. And that in itself, it's something we as researchers globally should look at and address. Let's talk about the research in the first world countries. These research trends are maybe driven by technology, and a lot of it has changed, and we will mention some of these. The abundance of resources, the patient's demands and other agendas, even governmental, institutional, organizational agendas. And most of these are driven by that. And of course, if you look at the pictures compared to the third world, it's very different. And we must think of it as different so that we can approach our research differently. When we look at the trends in the first and third world countries, and this is in terms of research, the trajectory is normally that third world countries want to emulate first world researchers, as they would feel left out of the research conversation. And there's nothing wrong with that. There's absolutely nothing wrong with that because we will learn more in that way. But we need to approach it differently, okay? Whether this approach, whether we follow them and whether that approach is appropriate or even relevant for our context is something we can all speak about. But we need to use that and learn from first world researchers, but we need to focus how we could apply that within our own context. So from the different perspective, the research agenda must be redefined. And I think if all researchers think about their context and how appropriate first world research would be within their context, or how they could use that first world research approaches and then improve or change their own context, that in itself would be a positive contribution. So the engagement, I would say, when we speak about our research agenda should be redefined, we speak about our engagement with first world research, our collaboration with first world research, using first world researchers to guide us or to assist us and to assist us across the different contexts. That approach is what's important, and that is what we should be focused. I've said now doing research differently, and I've said it a few times, but I think it is very important that you must remember two things in research. One, it must add value to the body of knowledge. It must add to the body of knowledge. It must add value to the body of knowledge, and it must make a difference to the status quo of where you are. If everybody focuses on research in that manner and still maintain these two values, I think the research can make great changes wherever we are. I think it's important to stress what's the primary goal of research. I think when we get involved in research, we tend to lose this kind of focus. For me, the primary goal of research is improve the quality care that we deliver to patients. I think our patients and the care we deliver to them is our main focus. Very importantly, when we do research on procedures and materials and all kinds of things so that we can decrease the risk of adverse events that our patients may experience. We want to decrease the risks to our patients. That's why we do evidence-based research. We want to improve the quantity as well as the quality of care delivered to our patients. We also want to improve our patients' quality of life. Evidence is not used at all sometimes. The results of this causes inefficiency and reduction of quality of life. So the question is, how is this goal achieved? How do we achieve this primary goal of research? How should we focus to achieve this primary goal of research? Of course, there are other goals of doing research as well. For example, when used in education. When used in education, we want to apply the research and update our materials used for teaching. We want to update our clinical procedures. We want to update our curriculum or review our curriculum. And this should happen on a regular basis, in fact annually, because council or your health council expects that of you. We also want to have improvement of knowledge of all procedures and all materials related to the practices, to our clinical practices. So the goals of research is vast. It's not just very individualized area. Of course, we do know evidence is most necessary, but of course it's not sufficient to change practice. We know that. We must have and use an all-encompassing approach. We do research to create evidence, and we want quality evidence. But we are also cognizant of the fact that there are certain resource constraints. We must be aware of other practices patient preferences when we conduct research or when we change practices, the cost effectiveness of interventions, the ethical considerations. We must be aware of all stakeholders involved when we want to use the evidence to change practice. We must prioritize certain works in order to create, to make the changes. So in order for that to be effective, we have to have and consider a lot of other factors before we use that evidence to change practice. A lot of the healthcare bodies and organizations have introduced continuous professional development, and it's an important step. And I think the fact that we still stay with it means there is some importance to it. It is there to update our knowledge by referring to quality evidence. But we know after all these years that these do not necessarily translate into practice. People are so comfortable with certain procedures and certain materials that they are very reluctant to make the changes. So there are no regulations in place to ensure that whatever knowledge people gain by being part of these programs, that it translates into practice. So this is an area where we need to reflect on whether it has been successful or not, whether we must need to make changes or not, whether we need to redefine what it is that we want from practitioners when we say update your knowledge. I think this is very important. This is another step to change. This is another area where we need to have changes, and that's very important. So over the years of doing research and conducting research and knowing it does not necessarily change into practice, we've identified this as a big gap. It's a gap that needs to change. So how do we then change this gap? And one of the important things to focus on when we want to bridge this gap between research and practice is to look at the type of research that we do. And that's important for researchers to know why this gap cannot be bridged so easy. So we've said a few times now, we need to do research differently. We've also identified that there's a major gap between research and practice. But I think if we think about why we do research, who do we do research for? Okay, and I'll speak a little bit about the individualistic approaches a little later on. But for now, I think if you speak about the idealistic approach, the idealistic mindset would be, we will do research in order to change and have good quality evidence, to change current practices using good quality evidence. But before we even come to that, if you just think about your patient, patients have rights over us. And one of their rights over us as practitioners, as academics, as researchers, is to receive the best decisions, the best treatment based on good quality research, based on good quality evidence. That is their right. And we cannot shirk that responsibility that we have. We have that responsibility as clinicians, as researchers, academics. So we have an obligation towards our patients to ensure they receive the best decisions, the best treatments, the best materials based on good quality evidence. Now, when you're in the education sector, it's probably easier done because we tend to review our curricula regularly. So we know what's out there. We tend to hopefully read what's out there. We want to use the best evidence when we teach. We want to use the best evidence when we do clinical practice, when we teach students clinically. As researchers, our focus and our approach should be to create the best evidence. It should be to ensure that our research is of such high quality that that evidence can be used to change the curriculum, can be used to change clinical practice. Similarly, practitioners should also be using the best evidence. But they're not involved in the research. So what we should be doing at this end, and it should probably be part of those CPD activities, would be to teach them how to read smartly, to obtain the best evidence, to change their practices, because it is their patients' rights to receive best evidence in terms of their treatment. And I think when your focus is different, you will think of it differently and you will practice differently. And that's an important message. Talk now about how we need to do research differently and what our focus should be. And our focus should be our patients because they have rights over us. But let's take a step back. Okay? How do we actually do research as researchers? We do research and we say what's of personal interest to us. Many of us have students. You want them to focus doing the research. You don't want to squeeze them to do research that you think is important, but they have no interest in doing that research. Okay? So we tend to do research that is of a personal interest to us. Another approach that we have is to do research that can be completed quickly. Okay? A lot of us do not like to do research, and that's a reality. Not all of us love research. I love research. I don't expect everybody to be like me and love research. So when a student is doing a degree, for example, whether they're doing it a master's or they're doing it even as a master's could be a small research project or it could be a large research project, or if they do it as part of their specialist training, they have to do a research module. So they want to do research because it's not their prime interest. They will do research that will be conducted and completed quickly, whether it is a specific methodology that they use, whether it's a kind of material research that they use, depending on the purpose of, as I said earlier, degree or speciality. They will do lab research even, because it is something that is less complicated. Another way of doing research that people do would be, for example, there are new topics on the market. For example, if it's digital research, if it's nanoparticles, if it's genetic research, things that are topical, they will focus on that. The other way people do research is, for example, new methodologies. The one on systematic reviews has in the last 10 years become a research that is very topical, a research methodology that's very topical. I mean, I've been involved with different types of reviews. You get different types, not just a systematic review, okay? New types of lab research that people would be involved in. So it's new kinds of methodology. If it's a new thing, they want to be involved with a new thing, okay? The same with the new buzz in the academic research now is to do research focusing on the sustainable development goals. Yet we've been doing research addressing some of these sustainable development goals. We just never focused it. We never used it as a buzzword. So that has become the new buzz. So that's how we sort of approach research when we do it. And I think maybe we need to relook at that and see how we can do research differently. I think the one thing that I do want to add, we've said there's a gap between research and practice. But what will ensure that the research changes practice? And the important area here would be the quality of the research that we conduct. If we conduct research using the focuses I've just previously described in the previous slide, then many a times the quality will be compromised. And that is something we should not be part of. We should not compromise the quality of the evidence that is produced, because that quality of that evidence is what can change clinical practice. So this actually is the most important approach or the most important mindset that we must have. I'm sure all of you You are researchers, we're at a research conference, all of you have seen this research pyramid or this evidence pyramid. And when we speak about quality, let me just very quickly highlight what is the best evidence. The best evidence would be the study that is done the most rigorously, and it would all be at the apex of this pyramid. This, initially, when we speak about the secondary type of research, would be your systematic reviews and meta-analysis, and just below that, anything as critically appraised. That would be good quality research. If you speak about good quality clinical research, and we speak about randomized controlled trials, these are the experimental studies that are very important, where the quality is of the highest quality, because these are done very rigorously. Now, if you look at the research that we spoke about in the previous slide, and we said the quick fixes would be your lab research, but you can see in terms of quality, these are really poor quality studies. And that kind of quality research cannot change practice easily. So it's the top end of the pyramid that we need to be involved in when we want to change clinical practice. Speak about the current trends of research, and I haven't even really touched on subject matter yet. Okay, when we speak about current trends of research, we do know people do research for their own interest. They want to have a degree, they want to do it for promotions, and that is their own kinds of agendas. Students come and go, but we need, as academics and as researchers that are based at institutions, we need to use them to address the goals that we as institutions set firstly. So we can sometimes do that. We can guide them to do research that addresses our goals. Very importantly, researchers do not, and they should start considering the impact the research they do have on the world around them, including Africa and the Middle East. Okay? You must look at how that research impacts on your world and your area. Okay? The quality of the research should not be compromised, especially. This is most important. I think as a student researcher, you don't think about the impact your research makes and the implementation of your research, but as the guide, the supervisor, as the teacher, we should be focusing on that. We should be teaching them and guiding them to show what an impact their research can make and how their research can be used to make changes in practice. Many researchers stop long before this. They think, yes, we're going to do research, yes, we're going to do a publication, and that's where it stops. They don't think about the implementation. But we, as seasoned researchers, should guide them to think about it. We also know that they do not consider the changes it might have on the curriculum, on the teachings. We should be guiding them to focus in that way. And of course, as I said earlier on, and I said it a few times, the changes the research can make to clinical practice. So when we have students, that's how we must think for them and guide them, because they as students come with their own agendas. All they want to do is they want to promote, they want to get their degree and hopefully a publication, and it stops there. But they do not consider the rest of the impact of their research. But we as their supervisors, we should be thinking that for them.
We would like to thank Dr. Khan from South Africa being with us online. Anybody has questions, he's live with us. So please, audience, if anybody has a question, raise your hand. إلهام, come on, سوي لنا جو. أسألي. لا هناك. Give her the mic, please. Dr. Khan, you can hear one of the audience will ask a question.
Can you put her on the screen? Can you put her on the screen?
She's not live?
She's not live?
طيب, send her by email the question. Thank you. طيب, now it's Asr prayer in Riyadh. احنا أهل جدة صلينا قصر وجمع، جاهزين حاضرين. بس أهل الرياض لو سمحتوا صلوا وتعالوا. We will wait for you. Our next speaker is a best researcher, senior researcher from Palestine, Dr. Ilham. Don't miss her talk, please. We have 15 minutes. ها؟ ليش؟ We start at 3. طيب 15 minutes. Please 15 minutes. الدكتورة ما هي لايف، ليش أقدم لها؟ Abdurrahman, tell people to come inside. في عندنا free gifts, coffee and sweets. I tricked you guys. I said 3 o'clock, but actually it's 3:15. I want you to come back to the hall. Actually, no. I thought it was we will start at 3, but the organizing committee told me it's 3:15. So we will just wait a few minutes, and I will introduce our next speaker. I don't want you to miss her talk. طيب, السلام عليكم. We're back to our session. Thank you for coming back. I shall introduce our next speaker, دكتورة إلهام الخطيب. She came all the way from فلسطين عشان تعطينا محاضرتها الحلوة وتعطينا her experience in research in public health. دكتورة إلهام, she's an American board public health diplomat, and she's an associate professor at dental public health at Faculty of Dentistry in Al-Quds University. صوت مزعج؟ إذا في echo ولا تمام؟ طيب. She's a research affiliate, public policy at University of Iowa. She's an adjunct faculty of Global Oral Health Department at Temple University. She's the chair of Public Health Committee at the FDI, and she is the Dean of the Scientific Research at Al-Quds University. Please welcome Dr. Ilham.
Can I have the microphone? Okay. Okay, you can have this. Just a moment. Okay. Thank you, Professor Samira, for this nice introduction. Thank you, IADR Saudi, for Dr. Al-Harithi, Dr. Dima, Amer, IADR. Thank you for having me with you in this great conference. I will be talking today about applying stages of readiness to change, an example of Medicaid participation in oral health, like using behavior frameworks in oral health service research. So as dentists, I think we all know how difficult to change behavior when we deal with our patients, when we deal with our community, but it's even more challengeable to change the behavior of healthcare providers. Many studies that used theories to look and explain how they can influence the change or the behavior change process among healthcare providers did not succeed to find the best way or the framework to explain and influence behavior change among healthcare providers. Different theories typically address different parts of the change process. And maybe this was the challenge, that using a framework that integrate more than one theory to explain the behavior and the change in behavior was an exception, not a common practice in health service research. In this lecture, I will first give an overview of stages of readiness to change. Then I will present an example that I worked with my colleagues in University of Iowa Public Policy Center. In this example,
I will focus on the policy relevance of our results. So the stages of readiness to change is one of the few examples of behavior frameworks that allow and permit the integration of different theories that can explain the behavior change. It indicates that behavior change is a process and that individuals at any point of time are at different readiness to change their behavior. And each stage of change is governed by different factors and influencers. Therefore, it is logical that we need always to identify where people are at on this continuum of stages of readiness to change. So, one of the most successful examples of using stage of change in health service research is tobacco cessation. And any one of you who may use tobacco cessation in their clinics and use the evidence-based technique, the 5 A's, the 5R technique to help their patients in quitting tobacco, they know about this model. I will explain this model in this context. Pre-contemplation. So your patient, if they are not thinking of quitting tobacco products, smoking, cigarettes, argila, whatever, and if they think it's not harmful, or if they believe in the harms of this tobacco product, but they think that they are not susceptible to it, so they are placed in the pre-contemplation stage. If something happened to them, maybe a relative dies or a friend from smoking, or they received a strong message from a lecture or from a presentation or from their doctors, and they started to think that the gum problems that they have may be related to smoking, the bad cough, the shortness in breathness, so that's when they are placed in the contemplation, the thinking stage. If they started to make steps to quit the tobacco cessation, maybe they start looking for resources, ask about quitline clinics, or maybe schedule an appointment with their doctors to talk about tobacco cessation, so they are in the preparation stage. When they start the action of quitting, they are in the action stage, and when they maintain this favorable behavior for more than 6 months, so they are in the maintenance stage. And those 5 stages are the original stages of changes of Prochaska and Calamenty. However, we are not in an ideal world. We know that subjects in the action and in the maintenance stages can go to their old ways, and they can go to smoking again, which is a stage that we called relapse risk, and it was added to the original 5 afterward in the literature. Although I presented this in a directional, vertical, way, but in reality, it's more a circular that you can, jump from one to another. So you can move from pre-contemplation to contemplation, to preparation, to action, to maintenance. Then you may suffer from relapse, and after relapse, it was very traumatic, so you go back to pre-contemplation or contemplation, or you can go directly to preparation. So if we can place our subjects, our patients, in any of those stages, then we can tailor a strategy or an intervention that is suitable to the to those in each stage. We can't prescribe intervention and strategies universally for all, because people are not the same in the behavior change process. So if we want to move people from pre-contemplation to contemplation, we need to have more awareness campaigns that increase or change attitude. If we want to push them from thinking to start preparation, we need more motivations, projects and intervention that motivate those subjects for action. We need to give them the tools. We need to increase their self-efficacy and confidence that they can do it. And then we need to support them to maintain this behavior. So stages of readiness change examples in health service research usually focused on the patient side, usually like on exercise, favorable diabetic care, and they show very effectiveness in those examples. And a few examples were focused on healthcare providers, especially in guidelines adoption, counseling service adoption, and both they show like good effectiveness of this framework to explain the behavior. In oral health service research, we can claim at the time of data collection that we are the first to use this stage of change in oral health service application. We used it in Medicaid participation. For people who don't know Medicaid, Medicaid is a state-funded program that provides health benefits, mainly medical benefits, to certain marginalized population, and some dental benefits. It's different from state to state, but children, women in general, elderly are usually included in dental benefits. The main challenge of Medicaid participation is the low participation rate. Whatever they do at a state level, they couldn't increase the participation. Dentists in the US are not willing to participate in the Medicaid and offer services for their patients. So maybe one reason that Medicaid participation is a complex behavior, as most of the behaviors, that include, individual, patient, community, organizational, and institutional factors. And that when they approach that problem, they did not, use frameworks that effective in addressing all those parts of the problem. In our previous work with the University of Iowa Public Policy Centers, we used a very interesting method that needs another lecture to talk about, called conjoint analysis, that identified most of the literature. They said that reimbursement rates, that the Medicaid program, pay less than the regular fees for dentists. That's why dentists are not willing to participate. However, in our study, we found that patients' behavior, like compliance and punctuality, and also the administrative ease of administrative processing of claims, they were as important as reimbursement rates. So when in Medicaid example, if you just ask people if you participate or not participate, you are oversimplify the decision-making continuum. And you neglect that there are participants who are thinking of quitting, and participants who are satisfied with their program, and non-participants who are not thinking of, participating in the program, but there are non-participants who thinking of participation. So the study that we did, the main objective was to identify dentists at different stages of readiness to participate in the Medicaid, then relate those stages to different predictor variables. We used the data from mail survey to all eligible primary care providers at the state of Iowa. And we sent a questionnaire that first composed with the algorithm that we will talk about, the stage of change question algorithm tool, and then a series of survey questions that we used to compose 4 scales. The first one, the altruistic attitude among dentists, and this was validated in another study. The attitude about Medicaid program, administration, and the attitude about Medicaid patients themselves, and the perception of Medicaid problems. So this is the tool, the algorithm tool that we use to place dentists in different stages of readiness to change. As you can see, we asked a series of questions that put dentists in different stages. So first we ask, do you accept new Medicaid patients? If they said no, so we put them in the no participation block. If they said yes, some new, we put them in limited participation block. If they said yes, all new, we put them in the participation block. For non-participants, we ask another question. Are you seriously thinking about starting to accept all or some new Medicaid patients? If they said no, we place them in pre-contemplation. They are not thinking of, participating in this program. If they said yes, we ask them another question. Are you planning to start to accept all or some new Medicaid patients in the next 6 months? We put a time. If they said no, in contemplation, they are thinking of participating, but they doing nothing in preparation for that, so they are in the contemplation. If they said yes, we are preparing to do this, so we put them in the preparation block. For limited participants and all participants, we ask them about how long have you been accepting some or all new Medicaid patients. If they said less than 1 year, then they are still in the action stage. If they are more than 1 year, so we hope that they maintain this behavior and they are in the maintenance stage. We ask the participants also, how certain are you that you will continue to accept Medicaid patients in the next year? If they said completely certain, they are in the maintenance, still in the maintenance stage. If we said somewhat certain, they are in the relapse risk, because now they have some doubts. Somewhat uncertain, not certain at all, they will all placed in the relapse risk. For analysis purposes, we collapsed those 6 stages in 4, the pre-contemplation, the contemplation, and the preparation in considering, they are considering to participate, the action and maintenance in the acting stage, and the relapse risk at the at-risk stage. We used ANOVA and post-hoc Tukey to compare practice characteristics and the 5 composite variables that we talked about, over or among those 4 stages. So of the 1,100 eligible primary care dentists, we have 651 completed the survey with a very good response rate in this kind of surveys, 59%. 500 dentists were included. We included only the dentists who were the primary decision maker in their clinics, so 500. And those are our sample characteristics, and when we compared them with the whole population of state of Iowa, we found no significant difference. Only in one category, practice type, there was statistically significant. We have more solo practitioners than the whole population of dentists in Iowa. So this is our first result. We can see here that 36% of dentists in our sample, they were in pre-contemplation. They were not thinking at all to participate in Medicaid. And 46%, they were at risk of leaving the program. If we ask the question, do you participate or non-participate, this will mask the 6% who are not participating, but they're considering the participation. And also we will mask the 46% who are participating, but thinking of quitting. So we think that this will give us more information about the intent of participation and the satisfaction with the program, more than just asking, are you in or are you out? When we did our bivariate results, we found that dentists in acting stage had more reimbursement money than people at risk, and dentists in acting has more number or percentage of the Medicaid patients in their pool more than at risk. We'll see the relevance of that. When we compared the four stages in the dentist altruism scale, we found that the more favorable one was among the acting, and it was significantly different than the people in the pre-contemplation. And when we compared the four stages with the attitude about program administration, we found the most favorable also in the acting stage, and it's significantly different than all other three stages. When we compare the attitude about the patient of Medicaid and their behaviors, we found that the most favorable one was also in acting, and it wasn't, and it is logical than those they don't have any statistical significance because they are not involved in the program, and we could find some statistical, but it's very weak. When it's become like one-to-one, it's very weak relation or association. The last scale about the problems of, or the importance of the problems of the Medicaid, we found that in the acting, they found these problems are not that important. So we claim that this is the first time to use stages of changes in oral health services, and that the focus usually on the patient side when we talk about stages of changes, but we suggest in this application that it can be used also with healthcare providers. And in this analysis, we succeeded to distinguish between participants and non-participants at different stages of readiness to change, and that Medicaid dentists who are satisfied, they are participating, but they are satisfied or they are not satisfied. And this distinction is very important because it helps, this is the most important point, that it helps match specific strategies and match it to the specific stage, and emphasize, as we said, that we can't just give universal strategies or universal, programs to everyone, and that changing behavior, we don't need only to focus in the intervention, we need also to focus on the stage of readiness that the dentist at, and we need to screen dentists first, then tailor specific strategies. In this sample, we can see that almost half of the sample were at risk of quitting the Medicaid program, and more than 1/3 were not even considering participation. So now the question for policymakers, you have always limited resources. Do you want to invest those resources in dentists who are already in the program, have the system already installed, but they have concern and they're thinking to quit? Or do you want to focus your resources on the dentists that they never been in the program and never thought to be in the program? So this question need the policymakers to, answer it. So they need to decide if they want to focus on raising on non-participants by raising awareness, motivation, and provide information or resources to start, or focus on the already participants and try to support them to stay in the program or address this concern to prevent them from quitting. Specific examples from our results, we know that in acting stage, like high percentage of their patient pool were from Medicaid. So if we negotiate better reimbursement rates on key services, that will be tempting for them to stay in the program. People at risk stage, we can give them periodic reimbursement rate reviews, simplification of administrative requirements, care coordination, services for the patient. This will be more tempting for people at risk because those are the main concerns usually for people at risk. People or dentists at pre-contemplation, I think the best way to address them by direct outreach to introduce the program, the benefits, the changes, and the benefits from this program to their practices. So, although that we think that this is a very good application and that a good example, all this data was based on cross-sectional data, and this is major limitation. It will be perfect if we can do a longitudinal follow-up and followed with those dentists, especially in the at-risk, and see if they really are going to quit, and people on the maintenance, if they stayed, and people in the contemplation, how they moved, among those 4 stages. And this is our next step in this research. Those are my references, and thank you, and I'm ready for questions.
Thank you very much, Dr. Ilham. Very informative lecture. لازم تخترعوا أسئلة. اخترعوا أسئلة. I need questions. Dr. Mishari. Mike, give the mic, Dr. Mishari, please.
Thank you very much, Dr. Ilham. What's Medicaid?
Okay, I mentioned that Medicaid, for the people who don't know, Medicaid is a state-funded program that offers in the US and gives health benefits to different. Okay, here now. Okay, so it's a state-funded program. It's not a federal program that provides health benefits, especially medical, to some marginalized populations in the US, and it differs, the benefits that it gives is different from one state to another. Thank you.
دكتورة مي تفضلي. دكتورة مي الخضاري. Give her the mic, please.
Thank you so much, Doctor, for your really informative presentation. It's interesting, the 4 stages, and it could be applicable, in other, as you said, smoking, a healthy lifestyle, etc. So the thing that I had a concern about is those dentists, of course, they don't have there's no reason for them to join this program if the Medicaid coverage, the reimbursement, is not going to cover their overhead costs. For example, when I was in North America, I was in Boston, so at Mass General Hospital, I was told by my supervisor, he's like, May, if they are Medicaid, don't spend that much time with them because the coverage is very low. So Medicaid, as you said, it's a national program, just like the NHS in England, but then the reimbursement is very low and it doesn't cover the overhead costs. So probably that's why we have the dentists that are not, in the pre-contemplation, and then there's a high relapse risk.
Yes.
So I think that is a big factor in your study.
Yes,
right?
yes.
Thank you.
Thank you, doctor. And anybody studied in the US, they suffered from this and, had involved in one way or another in Medicaid program. In my other study that I studied factors related, so all the literature, say reimbursement rate is the most important, topic, and even when you talk to dentists. But when we did our conjoint analysis, which is like a way to elicit like the hidden drivers, it's like, presenting scenarios and asking, it was surprising that patients' behavior was even as important and sometimes more important than reimbursement rate. So dentists, okay, give me like low reimbursement rate, but at least make those patients show up for their appointment, because one of the most important that they don't show, that you schedule, you open this, space, and they don't show for their appointments. And one way like to have care coordination for them, and even the claims, the administrative claims. So if you can ease those people, they are willing, this is from other, just make this claims process, easier. So they all say reimbursement rate, but sometimes other, factors are as important or even more important, and they can, work with them. They can increase. And for your first point, yeah, the objective of me presenting this to encourage researchers to use this model on different behaviors, patients' behaviors and healthcare providers. It's a very nice and it's very successful in many applications. And I would like to see more application for this in our, and yeah, thank you very much.
Thank you. Any more questions? دكتورة روالي من البحرين تفضلي.
شكرا دكتورة. Thank you for the presentation. Thank you, Dr. Samira. It got me actually thinking if we want to study behavior of dentists or practitioners in any other practice, wouldn't it be helpful to use qualitative study with or instead of quantitative, because that will get them to talk? And was it a part of your study, because I understand it is quite extensive? Thank you.
Thank you very much. This is a qualitative and a quantitative debate. People who are working in qualitative or were trained in qualitative think that qualitative is the best way to know about behavior, and people who were trained in quantitative will claim the same. For me, I think, combining both, it will be great. Qualitative, you can go in depth for reasons, and you can explore more, but you need to start with some, like big picture. So quantitative will be an easier first step to start with the big pictures, give some ideas to go more deeper with the qualitative. So I think both, they need always to address the same problem by both quantitative and qualitative.
Thank you.
Thank you.
Thank you. Anybody? Any more questions? I have a question. What's the smoking consumption globally and in your country?
So like in my country, I think like in Palestine, more than, they claim on the papers like more than 40%.
Okay.
They have smoking, but I believe from my practice it's even
More.
Yeah, and globally it's more than 40 or 50% globally, like smoking, and the problem that not all types of smoking are addressed.
Yeah.
So we need more surveys to know other types of smoking, like tobaccoless smoking, argila, water pipe,
yeah,
and
I'm
other
talking
type of
smoking in general,
smoking.
yeah.
Yeah, and this is another topic, that tobacco cessation among dentists, that maybe one time we will focus on it, and how to train dentists really in their practices to start, convincing and helping and supporting their patient to quit smoking, because in research, dentists are in a very good place to do this.
Any more questions? We still have time. I don't know why the young don't ask questions. When I was young, I always jump and ask.
Be encouraged and ask.
Anyway, thank you very much. On the behalf of the organizing committee, I would like to thank Dr. Ilham Al-Khatib to give her excellent talk, and this is a certificate of appreciation. Thank you. طيب, according to the schedule, we still have one more session. I will hand over to my colleague, Dr. Abdullah Shehri, but I think there is a small break. Then we come back. Don't miss the next lecture. دكتورة ليلى بهمام هتتكلمي على براءة الاختراع. يعني لا يفوتكم دكتورة ليلى بهمام. يعني she is the most Saudi dentist who has patents in the country. So don't miss her talk, please. Thank you. Says 4:15 in the program. Anyway, Dr. Harsi is the head of the conference here. Just please, we will start at 4 sharp. So you have maybe 7 minutes, and be back, please.
Okay, welcome back. For our third and last session, we will focus on innovation, and we are honored to welcome the respected Dr. Abdullah Shihri. Dr. Abdullah Shihri is an assistant professor and consultant in restorative dentistry. Dr. Shihri is the chairman of the Conservative Dental Department at the College of Dentistry, Prince Sultan bin Abdulaziz University. He has also obtained his master's and PhD from the University of Iowa in the United States, as well as a certificate of higher education and higher learning. Without further ado, please join us, Dr. Abdullah.
شكرا يعطيك العافية. Welcome everyone. I would like to thank the sponsors and organizers for making this conference happen. I am honored to present Professor Leila Bahammam. Professor Bahammam is a professor and consultant of endodontics and at the King Abdulaziz University. She's the head of intellectual property unit at the Center of Knowledge Economy at the university. She's also a board member of the Saudi Dental Society. She's working as a part-time at the Academic Leadership Center of Higher Education, Ministry of Education since 2014. And she's a representative of Technology and Innovation Support Center of the Saudi Authority of Intellectual Property. Previously, she was the supervisor of education and student affairs and at the Educational Clinic Director of King Abdulaziz University, College of Dentistry. Professor Bahammam is an inventor. She has several inventions and patents, approximately 30 patents in the field of dentistry. She won several local and international awards. She's a trainer in the field of endodontics, health education, leadership, and patents and innovation. She's member of several societies and associations, locally and internationally. Finally, she has several publications in the field of dental education and endodontics, and she participated in different international conferences as speaker and judge. She's a reviewer for several journals, including the BMC Oral Health, BMC Medical Education, and Dental Traumatology journals. Please welcome Professor Bahammam.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. I'm very happy to be with you today. And our session today is different than the rest of the day. It's about innovation. And before I start my lecture, I would like to talk about the position of the Kingdom of Saudi Arabia in the area of innovation.
This is your pointer, this is forward, this is...
The Kingdom of Saudi Arabia made huge jumps in the area of innovation. According to the Global Innovation Index, in the past few years, we ranked 66th among 132 countries. And this year, we ranked the 51st. Also, we ranked the 18th among 139 countries with more than 1,000 patents, according to the USPTO. And the number of patents that were submitted to the Saudi Authority for Intellectual Property in the past few months were more than 30,000 patents. Also, 4 of our universities ranked among the top worldwide university granted USP patent. And these are King Abdulaziz University, King Fahd for Petroleum and Mineral University, Al-Imam Abdurrahman bin Faisal University, and King Saud University. And the ranks were the 4th, the 25th, 58th, and 68th, respectively. Also, the Saudi Authority for Intellectual Property ranked the 24th globally as a patent office for the number of patents that were issued from Saudi Arabia. So this reflects the capability of the Saudi citizen, their innovation, and the investment of our country in the area of innovation and technology, as well as education. All of you heard about our vision 2030, and you know that our vision give a great deal to invention and innovation and patenting, because we know that this is the base of knowledge economy. Okay, now I talked about the number of Saudi patents for a reason. Now, what are the technical fields of these patents? According to the Ministry of Health from BATSNAP, they found that the first and second technical, the first and second technical fields of patents that are owned by the 27 Saudi public universities are in the area of, or related to dentistry. And the rest of the fields, if you combine these two fields, you'll find it 4 times higher than the rest of the fields. This indicates that dentistry is full of innovation, and it has room for improvement and development. Also in my university, dentistry ranked the second among the technical fields of patents that are owned by my university a few years ago, not anymore. So I'm encouraging you to have more patents. Okay, now what is intellectual property? Intellectual property is the creation of your mind, whether it's logo, photos, images, literary, anything comes out of your mind is an intellectual property. And it has several domains. These are patents, industrial designs, copyrights, trademarks, integrated circuits, and plant variety. And in order to understand the difference between these domains, I have this example for you. This is an iPhone, and most people think that application is a patent. No, application goes under copyright, whereas the patent is how the device is working, how the camera is attached to the battery, to the main part of the device. This is the patent. If you look at the internal electrical connection, it goes under integrated circuit. The logo of the company goes under trademark, and the external appearance of the device or the design goes under industrial design. So as you can see, one product, you can have several intellectual properties from one product. It depends on how do you apply, where to apply, and how do you write your application. Now let's talk about patents. What is patent? It is an exclusive protection document granted for the inventor for an idea that resulted in a solution of a specific problem. So if you have a problem and you come with a solution of that problem, you will be granting a patent document. This protection document lasts for 20 years from the date of filing. So if you file your application today, and you have your patent after 5 years, you will have 15 years left of protection. So it's from the date of filing and not the date of issuing. Patents could be products, industrial designs, machines, materials, composition, or an improvement of any of those. Okay, now, if we look at this chart, I consider it the journey of the patent. We start by identifying our problem, then we look for the appropriate solution to that problem, which is the idea, then we go and do prior art search, draw and write our idea, and finally file it at the patent office. If you look closely to this chart, it is a little bit similar to research journey, with slight differences. Now, let's start with the first step, which is problem identification. All of us are surrounded by problems and challenges, especially in dentistry. And most people, some of the people go and look for answers or solution to those problems. But most of the people will think that these problems cannot be solved, so they try to adapt to them and ignore them or bypass them, and by the time they cannot see or recognize these problems, so from now on, I want you to be conscious and attentive, observant and focused for all the problems that you encounter during your day, especially your work. And then you have to write it down. Documentation is very important, because if you do not write it, you will forget it. So I encourage you to have a small notebook specialized for this, or you can use your phone and specialize and just put it in a folder created for problem identification, and write all the problems that you encounter during your day, so in the future you can go back and try to find solution to those problems. Henry Ford said that most people spend more time and energy going around problems than in trying to solve them, and we don't want to be one of those people. Okay, in the literature, there are several methods proposed to study your problem, and the most famous one are the 5 whys method and the fishbone method. The 5 why methods, it's also called the root cause analysis. You ask several why questions in order to reach the root cause of your problem, so you can find the solution to the root cause and get rid of the problem. It's similar like if the patient comes to you complaining of pain. If you just prescribe analgesic for the pain, you are not treating the patient. You are just relieving his symptoms. But if you ask the patient several questions in order to reach the appropriate diagnosis, you will give an effective treatment. The same thing here. Another example, if you have a manager at a factory, for example, and he has the workers, they keep being absent. So if he stops there, either he will just send them warnings, deduct from their salaries, or even dismiss them and hire new one. But if he asks why they are absent, okay, they have medical issue. What's that? They have old back pain. So why do they have back pain? Because they are carrying heavy stuff. So why they are carrying heavy stuff? In their job description, nothing is mentioned about carrying heavy stuff. Because some of the items at the production line where they are working is falling down the floor, and they have to carry it and put it back so the production line will not be disturbed. So why is this falling down? So they keep asking why? And now the problem is not in the workers or the laborers, it's now in the production line. And if he keep asking why, he will reach the exact cause of his problem, and then he will go and find a solution to that problem. If he did not do this, he will keep changing his workers forever, and he will not get rid of his problem. The second method is the fishbone method. Also, it's used to identify the root cause of any problem. Also, it's called the cause and effect analysis. It is used in more complicated problems that has several factors contribute to their presence. They put the problem at the head of the fish, and then they analyze all the causes that contribute to the problem. Example, if they have, for example, the same factory, they have a product that is not up to the standards. So what are the factors that affect the quality of that product? Could be the materials used, the labor, the transportation, the storage, especially if it's food. So you go and look into all the causes that contribute to the problem and find which cause that caused the problem. Sometimes it's several causes, not only one. And then once you solve these problems, you will get rid of, solve these, problem, you will get rid of the problem. If one did not analyze the problem and go and solve only the most obvious cause, he will not get rid of the problem. And this is the way that we go and study our problem in order to invent. So we define the problem, analyze the problem, we look into symptoms, causes, and consequences of the problem as you are studying the problem in the past, present, and the future. Once you understand your problem, before that, Chesterton said, it's not that they cannot see the solution, they cannot see the problem. If you know the problem, the solution comes easily. It's like when we say to our students, asking the right questions help you find the right answer. If you keep asking the wrong question, you will never get the right answer. Okay, now we understand our problem. So the second step is the idea or finding the appropriate solution to our problem. And there are also some methods proposed in the literature, and the most famous one are the brainstorming, Scamber, and Therese. Brainstorming, this is also called Osborne method. It's by generating as much ideas as possible, we can then select the most appropriate one, so the quantity will generate the quality. Of course, we don't judge any of the ideas that is given at the brainstorming. Because he said that it is easier to tone down a wild idea than to think a new one. That's why he put some principles for brainstorming. Never criticize ideas. We have to build on others by deleting, adding, or paraphrasing, and we encourage strange and exaggerated idea. Never judge and say this is simple, this is silly, this is irrelevant. No, because these ideas will deviate or direct the thinking of others to give more creative ideas. The second method is Scamber, and also comes from Osborne. And Scamber is the first word of these verbs: substitute, combine, adapt, modify, put to use, eliminate, and reverse. And if you use any of these verbs or a combination of some of these verbs, you will have creative ideas. I encourage you to go and adopt this method in your daily life. It will help you solving a lot of your problems. The third method is TREZ, which is a Russian acronym of Theory of Innovative Problem Solving. This method is done by a Russian scientist and his group. They studied more than 2 million patents. They studied the patent literature and come out with this 40 innovative principle. They found a pattern among the patents, and they come with this theory, which is a systematic way to guide creative thinking in solving problems. You can also adopt one of these or two or as many as you can, and you can use it in your daily life, and you will have innovative ideas. When you study your problem, ideas not always comes immediately, because there are stages of creative thinking. First stage is preparation. When you study your problem, this is the preparation stage. The second stage is incubation, where all the information is in your head, and then suddenly, in the illumination phase, you will have your brilliant idea. And after that, and it always come in a very strange places, and I'm going to talk about it in a minute. Once you have your idea, you have to verify it. And verification means you have to test your idea to make sure that it's the appropriate solution to your problem. It's easy to use, will be used, and look at the cost and price of your idea and compare it to the market. You don't want to have complicated solution with which is very expensive. Nobody is gonna buy it. This is Johnny Eve. He is a senior vice president and a designer, the chief designer at Apple. He said that 80% of their designs are in the garbage. And 20% is what make Apple, okay? So if our idea did not work, it's not the end of the world. You can go and find another one and another one. See, 80%, if 80% we consider it failure, Apple is a very huge company, from 20% of their work. So do not give up. I lost a lot of my patents at the beginning because of lack of experience. So it's okay. But at the end, alhamdulillah, I'm an inventor and I have a quite number of patents. So don't give up. Also, he said that we shouldn't be afraid to fail. If anything is not good enough from the beginning, you just stop doing it and look for another thing. I mentioned that, according to studies, ideas come in very strange places. And these places are like doing shower, doing physical work without really thinking of the problem, okay? At that time, usually whatever is bothering you, usually it goes in the subconscious and your brain is looking for a solution to that problem. So, and at that phase, we call it the most creative phase, which is the theta phase of the brain. So you will have the solution of any problem that was bothering you in the past few days. So I encourage you to document it immediately using your folder or a small notebook, because you will forget it. You have to write it down. It happens to me. I really forget it, and till now I regret it, okay? So you have to write it down. Even if you don't like the idea, later on you can modify it or make it better. But whatever idea you have to document it and write it down. If you have an idea that needs other expertise or other specialty, it's better to collaborate with others, because the product will be much better than if you work alone. Also, if you have several ideas, it's better to use the easiest and the cheapest one. So now we have our creative idea. Is it patentable? In order to patent your idea, it has to have several criteria. First, it has to be novel, useful, and unobvious. If you have these three criteria in your idea, then you can go and patent it. So, in order not to lose the novelty, you shouldn't present or publish your work before filing. You don't have to have the document with you. At least file the application at the patent office. So once you file it, then you go publish it, present it in a conference, do whatever you want. But before that, never speak about your idea. Otherwise, it's not new anymore. This is according to the Saudi Authority for Intellectual Property. Discoveries, scientific theories, mathematical methods are not patent. Schemes, rules, and methods of running businesses, sometimes they have business plans, and these things are not considered, or games, mental activities, these are not patents. Plants and animal, any process or generation, these are not patents. They're considered as اكتشافات علمية وليست اختراعات. Unless it is microbiology, they can consider it patent. for a reason. يعني we will not go through this. Also methods of treating humans and animals or diagnosing humans or animals are not considered patents, only the products, okay? Because they don't patent it here in Saudi Arabia because they want everybody to benefit from it. So treatment, diagnosis, these are not patents, only products, okay? Now we studied our problem. We came with the brilliant idea. We have to go and do prior art search. What's prior art search? It's everything that have been disclosed to the public, whether it's something you read, you listen to, you see it on TV, anywhere that's considered a prior art. And we usually go and do this actually at two different stages. First, after our problem identification, to make sure that sometimes there might be solutions that are present that I'm not aware of. So I have to go, instead of looking for a solution, and there are solutions in the market, so I have to go and see, is there any solution in the market? And if it's not good or there is nothing, then I will go and think of an idea. Then after I come with my idea, I go and search again to make sure that this idea is new and nothing is similar to it. Okay? Where to look? We go and look into books, magazine, ads, product in the markets, general knowledge, scientific paper, conferences or seminars. Anywhere you can look for as a prior art search. But there are specialized engines for patent search. Some of them are paid and some are free. But as a beginner, because searching patents is by classification, and it's like letters and numbers, and for beginners it's a little bit difficult. So I encourage to use Google Patents because you can search via keywords. So use Google Patents and Google Scholar because most of the patents come from research projects. Some of the researchers do not patent their work, so you might find solution also in the literature. So you have to search these two websites. If you did not find your solution there, then you are ready to go and patent your idea. So the fourth step is to draw and write the idea. First, we have to write in full details. And if your idea need drawing, the drawing should be clear. You have to fill the forms, and the forms that you downloaded from the patent office of your country. Here is Saudi Authority for Intellectual Property. And then if you are a beginner and you don't know how to do that, I recommend to you hire a lawyer because there are some legal terms, especially in the claim section, so they will help you in writing your application. In my position, I have a lot of consultation and people ask me how to write out their ideas, and when I ask them just write whatever you know, some of them they don't know how to write. So if you cannot explain it simply, you don't understand it well enough. Okay, so you have to go and study your problem, make sure that your solution is the appropriate solution to that problem. And once if you follow the scheme that I show you, you will be able to write or fill your forms. Okay, why should I have a detailed description in my patent application? First of all, because if you submit your application or your form, you cannot edit or add to it. So, for example, let's say this is your patent, and this is what you write. And then the examiner said there send you an application, your application is rejected, and send you a lot of patents that are similar to this. And then you said, no, mine has more details that are not present on this. Did you write it down? If you did not write it, it means it's not there. And the patent will be rejected, and you will lose your idea. So from the beginning, you have to write in full detail. Don't rush and apply unless you are covering everything of around your idea. The second thing is the more you write, the more claims you have. And the claims is the most important part of the patent document because it defines the boundaries of your patent. This gives you the protection. The more patents you have, your patent is more protected so nobody can copy or do similar things similar to yours. The third thing is the more you write, you might have more patents because even if it's one product, okay, but it has several things that or several functions, several procedure, and each one goes in different classifications. So they will divide your patent into several patents, and you might have more than one patent, and it happens to me. So I just have an idea, and then I got, for example, 6 patents out of it. It depends on the writing. The drawing, not all patents need a drawing, but if it needs, it has to be 2-dimensional, black and white, no colors, okay? And it has to be professional drawing. Use an application or a program. I hire somebody to do this for me. I don't know how, I just write, although I can draw very nicely, but I draw it, I give it to the expert, and he did it for me, okay? The drawing has to be labeled because you will refer to these in the text. And for example, you will write the mirror, number 1, attached to so-and-so, number 2, which is so-and-so. So when the examiner read the description of the drawing and look at the drawing, will understand how your idea is working. Okay, if you will hire a lawyer, okay, and it's not necessarily because lawyers are very expensive. You can do it by your own, it's okay, but you have to go and read several patent documents in order to know how the forms are filled, especially the claim section, you know, because there is a specific way of writing claims. If you are gonna hire a lawyer, he is not gonna write for you. You have to provide him with everything, and then he is gonna rewrite the things and fill the forms according to the information that you gave it to him. So you have to give him a full detail of your invention. You have to give all the prior art search and write the similarities and differences between prior patents and yours. And if it needs drawing, you provide him with a drawing. So he will get the correct idea. You don't want your invention to look like this, and this is what the lawyer submit. Okay? Now let's go to the patent application. The forms, there are only 4 types of forms. The first one is the abstract, and in the abstract is less than 1 page. You write about the problem and your invention and how it solved the problem, briefly, 1 page. And then the drawing, as I show you, and then the detailed description. And this is the main bulk of the patent document. In the detailed description, you will write about the background of the problem. So you already studied your problem, so you can write easily this part. And then you write about your invention and how it solved the problem, okay? Then you write the technical field of your invention, Then description of prior art. You write all the patents that are similar to yours and what are the similarities and differences between those and yours. And then you summarize the whole thing. Then you give brief description of the drawing, as I told you, and refer to the numbers and labels that are on the drawing. And finally, you repeat the whole thing in detailed description. So beginners, when they look at the documents, there is a lot of repetition, but that's the way it's written. It has to be written this way, okay? The last or fourth one is the claim section, and this is the most important part of the patent document. This is the Arabic version. طبعا here in Saudi Arabia, we have to apply in Arabic. كل بلد بلغتها الأم. Here in Arabic country, we will apply in Arabic. For example, if we are going to apply in China, it will be Chinese, America, English. It depends on the country that you are going to publish your work, to submit to the patent office of that country. The claim, as I mentioned, it's the most important part of the patent document. It defines the boundary of the patent. It includes all the main and important features of the invention, and which is distinguish it from the prior art. So my invention has so and so and so, that's new, not present before in any other invention. And it has to describe structural and compositional features and never advantages or function. يعني أنا ما هقول it's lighter, faster, cheaper. No, it has to have tangible features. It has to be structural or compositional features that distinguish it from the prior art. The final step in our journey is filing. Now, where to apply? You have to know that patent document is a territorial in nature. For example, if I have my patent document from here, the Kingdom of Saudi Arabia, it means it's only protected here in the kingdom. So, for example, if it's in Kuwait, Oman, Egypt, anywhere they can copy and they can manufacture, sell my product, and I cannot sue them, because mine is only protected here in Saudi Arabia. So before I apply to a patent office, I have to study my product. I decide from the beginning where is the market of my product. And then I choose one or two countries, because I cannot have worldwide protection, because this is very expensive. So I choose one or two countries. And then I have either one of two ways. Either the PCT, which is a single international application, and this can be done through the patent office, the local patent office, or I apply multiple and separate application to the patent offices that I choose, and it has to be within 12 months. For example, if my patent is, I submit the first one January 1st, so before January 1st, I can submit anywhere. After January 1st, it's not new anymore. It will be rejected. So I have 12 months only to submit anywhere, okay? The best, if you ask me, I think BCT is better, because they give you 18 months extra for over the 12 months. So you can think more about is it really worth it to go and submit it elsewhere? If I want to file, how I can get get to the patent office website? You just write patent office of whatever country. If I forget about the Saudi Authority for Intellectual Property, patent office Saudi Arabia, you will have it already there. Patent office, the second one is USPTO. The third one is the European. You just write Korean patent office. Whatever, you will find it immediately in Google, okay? Now, I'm filing my application, okay? I file before my paper get processed. First, I will deposit the fees. and we'll have 2 types of examination. It's similar to when you submit your manuscript. The first one is the editorial board. They look into just the forms are filled correctly, the drawings are okay, and everything is okay. بنسميه الفحص الشكلي. Once it passes the first one, it goes to the second one, which is الفحص الموضوعي. Okay? They go into details. It's like when they send your manuscript to reviewers. Okay? And each one of the examination, you have only 2 times. The first one is okay, even if it's get rejected, it's okay. It's not that serious. But the second one is very important, and I'm going to talk about it in a minute. So the first examination, they will look at your papers, and your forms are correctly filled. The drawings are okay. If they have any comments, they will reject your application. They will send it back to you with the comments. You will go and read the comments and correct your application. And then you have to pay fees for that, the examination fees, which is 50 riyal. And then you submit it again. It's supposed to be okay. It will go now to the second examination. In the second examination, here the examiner will go and read the whole document. And usually they go and search in the prior art search in a very specialized patent search engines. So they come with more patents that you did not encounter. So it's okay if it gets rejected. They will send you the new patents and will tell you that these are similar to these, some of your ideas. So you have to reply back and tell, for example, if it's correctly similar. So usually the claims, for example, if it's 20 claims, some of the claims will be deleted because of whatever they found, but at least there are some will be accepted. But before, of course, when they reject it, they will give you the reasons of rejection. So you'll go and answer all the questions. Here in Riyadh, it's very easy for you to go and meet the examiner in person and sit with them, he or she, before you submit your correction. You don't want, sometimes they don't understand, it's so and so. No, they have the upper hand. They have to accept whatever you're gonna submit. So be careful. You follow whatever they say, okay? So you go and sit and come into mutual understanding. If some of the claims they don't like and you could not argue, okay, but at least there are some will be accepted, so you will not lose your patent, okay? For example, me, and I'm from Jeddah, I call and have an appointment over phone to make sure that my idea will get accepted, okay? Because after the second, if I have second rejection, it means I lost my idea. I cannot submit it anywhere anymore. Okay, so you don't want to lose your patent. Okay, and then once you sit with the examiner, you agree on the things that you're gonna send, because sometimes they don't understand what you're writing. And sometimes, for example, you say, no, but it's so and so. Did you write it? If you didn't write it, it's not there. So you have to sit with them, because sometimes the idea in your mind, but it's not translated in the paper. So you sit with the examiner, and then you answer all the questions and then submit it again, and hopefully it will be allowed. Then they will ask you to pay the issuance fees, which is about 400 riyal, and then they will send you the document. This is how a patent document looks like. This is from the USPTO, and this is from the Saudi Authority for Intellectual Property, الهيئة السعودية للملكية الفكرية. Okay, now let's look to the patent document. The patent document has legal and technical information. The patent document is not one page, it's a booklet, and it depends on your idea. Sometimes it is a very heavy one. So the legal information is usually in the first page. It has the title of the invention, the owner, the inventors, when it was issued, when it was filed, if there is a lawyer and the name of the examiner, everything legal is written in the first page. Then the technical information. Of course, it's in the other pages, started with the abstract. Here, it has all the details needed for any guy specialized in this area of invention to come up and build the whole invention. So it's like a manual, as if you were buying, for example, whatever machine comes with a manual, you read it, you put it all together. The same thing here, it has all the information needed to have the patent. Also, I would like to talk about industrial designs because these are much easier to get. But as I told you, industrial designs, it only protect the shape or the design of your product. For example, this one, it protects only the shape, but it has functions. So I have to submit it also as a patent. And if I'm going to submit both, I start with a patent submission and then the industrial designs submission. Okay? The industrial designs is very easy to get. You just give them the photo of the final product with the title, and you will have it within 1 or 2 months. But you have to give them the final product. Either you do the prototype and you take a picture of it, or you ask also somebody professional to draw it for you as a final product, colored 3D picture, not 2Ds, in order to be accepted, because they're so meticulous about the photos of the industrial designs. So, and the protection of the industrial designs, it's only for 10 years. It's not 20 years like patents. This is how it looks like. Industrial design is only one or two, I forgot, page. And it has to have features that is not present in other designs present in the market. Okay, so now why to invent? طلعت روحي ليش؟ Okay. First, scientific contribution. It's like research. You contribute to the scientific environment. Also, it's a very good investment opportunity. Also, you can participate in local international scientific exhibition. This is one of my invention. I got the gold medal of the exhibition and 2 different special prizes from 2 different countries. So one invention, in one of the exhibition, I got 3 prizes. Also, you can use it for promotion, and it's a very nice thing to have in your CV. Okay, at the end, I want to say that invention is a process. You don't get there overnight. It might be a long process. Difficult maybe at the beginning, not because it's difficult, but because of lack of experience. But I encourage you to go and explore it. It's a very nice journey, and if you follow my recommendation and instruction, I'm pretty sure you will succeed. These are my references, and thank you for listening. If you have any questions, I will be happy to answer you. These are my contacts, and at the end, I want to tell you that believe in yourself and you will be unstoppable. Thank you very much.
A very informative and interesting lecture. If we have any questions.
Thank
you so much for the interesting lecture. It just reminded me with all the entrepreneurship programs that I was like exploring in Boston. I have a question about the patent. So you can patent a product and all of that, but what about the process? Like a unique use of something in a way. Can you patent that as well? And also, for the things that you are maybe kind of, it's like a pamphlet or something, or a kind of instructions that is very unique. Is it like copyrighted, or what kind of process that I should follow for these kind of products? Yeah, thank you.
Okay. The first question is the process. It depends on the process, what process. For example, I mentioned that if it's like a work process or something, but if it's a manufacturer process, something that, how to, for example, have a product at the end, yes, you can patent it. But if it's like a plan of a business plan or something, no. The second one is?
Something like unique that you come up with, like the content, I mean.
It's a copyright. It's not a patent, yes.
I see. Do you have an idea, like, how is this process here, or?
Okay, if you want more information, I encourage you to go and look at the Saudi Authority for Intellectual Property. It has a very huge information. All patent offices, websites, they have the information in Arabic and English. You can go and read, educate yourself. There are even courses and it's free. You can go and attend educational material. The WIPO is very good also source of information. You can go and they have a lot of courses. Some are free and some are paid. بس حقنا حق الهيئة مرة ممتاز وببلاش فيعني you can go and educate yourself freely.
Thank you so much.
أتوقع في سؤال ثاني هناك.
Thank you, Dr. Leila, for your lecture. My question is, do we have to support our patent with research? Do we have to back it up with any evidence-based research?
You don't have to, but yeah, of course, why not?
Like, we just need to file it?
If you file it, you will get the patent document, which is a protection for 20 years of your patent. So you can like go produce it and sell it. Nobody can interfere with it. But if you can use it later on and do a research on it, yes, and you publish it. This doesn't interfere with this. It's up to you. But if you want to do that, you start with filing the patent, then you go and do the research. Or you do the same. You file and submit at the same time. You can work parallelly. Okay?
Dr. Leila, it was an amazing, brilliant presentation, and we're all excited, I think, in this room to our New Year's resolution to invent something, innovate. So my question is, what do you recommend? Do you recommend a 3D colored drawing of your final product, or a prototype? I mean, from your experience, what do you think would boost its acceptance? I mean, provided we have the proper proposal for submitting the paperwork for the patent, and then the industrial product itself.
No, patent is different than industrial.
The industrial product is the product.
Yeah.
Okay. So when
if
we
idea, it's better to patent. If you just have a design, you will go to industrial design. Which one, drawing, or it's up to you. Sometimes it's very difficult to do the prototype, very expensive, so you can do the drawing. But sometimes it depends on the examiner. They prefer prototype here in the Saudi Authority for Intellectual Property.
Okay.
But it's okay to have 3D picture like the one I showed you. You know, it give, I mean, something, يعني الدrawing خليه كأنه it's the final product, as if it's a photo of the prototype that you make.
Okay, and this would be a graphic designer?
Yes,
or?
yes, yes.
Okay, thank you so much.
Thank you, Prof, for the enlightening talk about the invention. I'm sure we are all excited and we are proud of your achievement. I want to ask first about the office itself. You mentioned that we have more than one office to submit the patent to, and about what's next. So let's say I have a device or an instrument that, or let's say an idea, and I don't want it to stop as an idea. I want to proceed with prototyping or manufacturing later on. Will the choice of the office itself play a role in this? And then what's next? If let's say I want to manufacture it, are you aware of any organization or any platforms here in Saudi Arabia that can connect me to, let's say, factories or somewhere else to help me produce it or not?
Okay. Regarding the patent protection, that's the thing that the patent office do. The next step is your responsibility. You can go and look for companies that can advertise or manufacture your product and sell it. There are some, but I'm still looking صراحة. يعني ما وجدت يعني أحد كذا كل الناس تقول لك you go by yourself. No, أنا أحب أعطي الخبز خبازه. أنا هذا ما هو شغلي. أنا ما أعرف له. This is my territory. أنا I'm good at thinking, giving good ideas, coming up with patents, but I need somebody to advertise for me. أنا المرحلة هذه لسه شوية I don't have that much experience into it. Okay.
Thank you very much about this. Just to clarify, is the patent given after proven efficiency and efficacy in solving the problem, or just the idea to solve the problem? Yes, like for example, you create, for example, a mirror.
Okay.
So the patent is given just for this idea, not the proven efficacy or efficiency of that mirror in the clinics, for example.
Okay. Now you have a problem, and you come with this mirror to solve that problem.
Yes.
Okay.
Yes.
And then you want, but you have to say, you prove it that it's working, but it's not necessarily before patenting.
Yes.
But
This is my question. How they will patent something may be proven not efficient?
Okay, no. See, you can. Just to make sure that I get you right.
Yes.
You said that you have a patent and you're not sure that it is efficient, right? Okay. At the beginning, it's not necessarily. You can patent it. Okay? But you have to, before you market it, you have to go and do prototype and test it, because sometimes, even if you patent it, there will be some modification that you didn't think of it. So it's better to do it from the beginning, but if you didn't, it's okay. You can patent your idea, and then later on, when you're doing your prototype, you change accordingly to have the final product in the market.
So they are not asking about the proof of validity, for example, or how it works, for example.
You have to write in the patent. You have to write. You have to write how it works and how it solves the problem.
Being tested.
Not necessarily.
Not necessarily.
Not necessarily.
Not necessarily.
It's better to test it, but it's not necessarily.
Okay. Thank you. Thank you very much.
Thank you, Prof. Leila, for this enlightening lecture, and I have a question on my own, if you allow me. If our respected doctor has a patent, that a mirror that solve one problem. If I read his patent, and I found theoretically that there's another problem, that if I did a modify to his mirror, it will solve another problem that he did not solve it in the first place. Can I file a patent for this modification?
If the idea is not obvious. يعني غير بديهية. يعني رجل المهنة ما يقول لك هذا عادي. It's common sense. يعني حاجة فعلا جديدة can be patented. يعني احنا قلنا 3 categories. It has to be new, useful, can be manufactured, and unobvious. Sometimes very slight modification, they consider it obvious,
so you cannot.
Okay.
Okay?
Thank you.
Usually, my invention, I start with one problem, but because I'm thinking, sometimes I don't do prototype, but I imagine working with it in my head, so before I write it. So I find several functions and use to that, as if I'm doing it physical, but it's in my head. So I write more details. So I have more patents. Some of my inventions have several patents because several, as I told you, several classification because of several use of that patent.
ثانك يو بروف ليلى. بسألك باللغة العربية الغالب العرب. فطبعا أشكرك على المحاضرة القيمة اللي هي أكثر من مجرد محاضرة وختامه مسك إن شاء الله تبارك الله. بس في سؤال يدور في بالي، أتوقع يدور في أذهان غالبية ما شاء الله تبارك الله إلى آخر ساعة موجودين، وهذا يعني من قيمة المؤتمر وقيمة السبيكر. السؤال اللي يدور في بالنا كأكاديميين، ستودنت ودنتست أو ستاف، في حالة إنه واحد عضو هيئة تدريس في جامعة وبيقول يسوي فكرة. طبعا الجامعات فيها اللي هي الأقسام بعضها كلوزد، يعني مثلا عندنا في جامعة أم القرى لما حد يسوي ابلكيشن، الابلكيشن موقف لأي اختراع للأسف الشديد. فلو عضو هيئة تدريس قدم في مكان آخر، مثلا أم القرى قدم في جامعة الملك عبد العزيز أوبن، أو واحد راح قدم في اللي هي الهيئة أيوة السعودية اللي هو اللي هي كاكست.
صايب
هذه جزء منها من كاكست صح؟
لا
ما هي
الهيئة السعودية
لا مدينة الملك عبد العزيز. مو في هناك التقديم أيضا؟
ما أعرف.
أيوة، فلو واحد قدم لهذه اللي هي اللي ذكرتيها، التقديم هذا للجامعة أي حقوق أو أي مثلا حق اعتراض، أو مثلا لو واحد مثلا سوى ما شاء الله ربنا فتح عليه وسوى فكرة صارت بعدين منتج أو حاجة أو شيء، كونه عضو هيئة تدريس وقدم الافلييشن حقه لما سوى الابلكيشن انه affiliated this university، this may يعني فهل لها اي نقطة قانونية او شيء او كذا من خبرتك؟
من الابلكيشن هذه الاشياء تكون اول واضحة وصريحة، في agreement مع الناس اللي هم بتشتغل.
ايوه
انتم مقدمين مين الاونر حق هذه الباتنت، it's written there. يعني احنا لو تشوف مثلا حقتي جامعه الملك عبد العزيز هي الاونر، انا ذا انفنتور، بس في حاجات حق الهيئه هذه حقتي، يعني في حاجات حقتي في شيء حق الجامعه. ف من البدايه ينكتب اسم الجامعتين عادي، وينحط هو مين اللي بيدفع هو اللي يحط اسمه. اوكي if they're gonna participate خلاص ينحط اسم الجامعتين عادي، 10 جامعات حتى. فكل شيء من البدايه يقرروه الباحثين مع بعض وتتكتب والحقوق ما تضيع.
تمام، يعني بس الجامعة بعد كذا ما لها حق مثلا لو ما قدمت او ما قدمت من خلالها؟
لما حتحط اسمها فلا
لو ما حطيت اسمها. طيب انا ما بيرسونال ابلكيشن
مو لازم مو لازم تفصيل.
شكرا.
دكتور وين تراي حتى المكاتب الخاصة اصلا اول سؤال يسألك المحامي هذه براءة اختراع تبع مين؟ طيب يو هاف تو يعني ديسكلوز، اذا كان تبع جامعه حيكون هذا لازم له طريق مختلف، هو اللي اصلا المحامي حيسالك ذا الشيء. فبناء على كده انت يعني احنا مثلا تحط الافليشنز حقتك عادي بس ما هي تبع للجامعه، لانه هي دائما الجامعه تاخذ اجريمنت برسنتج معين، لكن يمكن يعني انت تاخذ هذا لا انا ابغى اكون براءه انا وات ايفر، اذا يعني تحملت سوقت اي شيء انا يكون الدخل لي التابع نهائيا لي.
ولو قدمت حتى في الهيئه ممكن تحط اسم الجامعه كاونر، بس هم بيعتبروها مؤسسه. المؤسسات السعر حقها غير الأفراد، الأفراد مدعومة من الدولة، المؤسسات حتدفع مبلغ وقدره وحتلاقي نفسك أنت اللي بتدفعه. فإت ديبيندز. أدخل في موقع الهيئة وشوف كل شيء موجود في موقع الهيئة. أوكي؟ العفو. في أي سؤال ثاني؟
الله يعطيك العافية دكتور. كثرنا الأسئلة بس one more question.
تفضل. طيب.
You know we present too many great ideas. مثلا at a conference we present at a conference abstract but then we realize it's a great idea. Do you think it's still worthwhile to pursue a patent even though it's presented as at a conference? Not necessarily published but presented.
هل في evidence إنه you present it? Is it on the net?
on their database, on the conference database. It's there.
Is it published? I mean, يعني الباتنت اوفيس يقدر يدخل ويشوفها؟
Probably not. It's just an
يعني it
example.
depends يعني لأنه هم حيروحوا and they will go and search. هيعملوا prior art search. If it's present in the net عندك 12 شهر في أمريكا، عندنا هنا ما يقبلوا. Sometimes إذا حاجة conference يعني مهم وزي كذا أحيانا تغاضوا بس عندك سنة. بس عادة لا. فإذا ما هي موجودة على النت you can go. If not ما له داعي.
Okay. الله يعطيك العافية. شكرا. Any more questions? الله يعطيك العافية بروف ليلى. So this concludes day 2 of the conference. We'll see you tomorrow virtually, inshallah. Thank you and have a nice evening.
Thank you very much, Dr. Abdullah Shihri, for your moderating the session. Thank you, Prof. Leila. It was really a very nice ending for our session today. I would like to thank you all, our respected attendees, speakers, organizing committee. I would like to remind you as well, inshallah, today is the last day of the on-site conference. However, still we have tomorrow really a very nice program that will start from 10 a.m. up to 7 p.m. So all of you, you received the Zoom link. So please join us tomorrow. Inshallah, will be the last day, and we have still a lot of speakers and very important lectures. Thank you very much. Dr. Al-Harthi.
ثانك يو. كما ذكرت الدكتوره ديما ان شاء الله تعالى نشوفكم بكره فيرتشوال، لكن بما انه هذا هو السيشن الاخير حضوريا نقول يعني خالص الشكر لكم، وجودكم، حضوركم ومعنا تو ذا لاست مينيت. الشكر لجميع المنظمين طبعا، اللجنه العلميه، السبيكرز اللي بكره فيرتشوال they are not less يعني في اهميه وتميز عن السبيكرز اللي يعني they were يعني presenting on site. يعني very big names and very distinguished speakers, but some of يعني most of them they couldn't come due to visa or due to their schedule. So please try يعني to attend, and this is يعني part of the conference. Thank you so much for you all, for our distinguished speakers and the committee, scientific committee and volunteers, and to everyone. Thank you.